region. I want to say a big welcome to you all. Thank you for coming. Our invited guests, our speakers, our participants, Agsm presenters for both oral and poster presentation. I want to say a big thank you. We also want to say a big thank you for those who are coming from outside the country. Nebraska, I'm told, you are here. I say, let's give them a big round of applause for coming all the way. We also have some participants from CHOP, the Children's Hospital of Philadelphia, also here. Let's give them a round of applause. And then we have local participants like us who are from Ghana. We want to say a big round of applause to ourselves. So welcome, welcome, welcome. Okay. We're going to be moving on to the next part of the program. I'm honored today to introduce a woman whose passion for children's health is not just professional. It is actually deeply relentless, truly inspiring, and very personal. I'm talking about Dr. Hilda Montego. She's a pediatrician at the Hollywood Teaching Hospital, also a time lecturer with the University of Ghana Medical School. And she is our dynamic president of the Pediatric Society of Ghana. Over the years, she has led several courses, both national and international, influenced policy, mentored generations of healthcare professionals, and she continues to champion the vision of leaving no child behind. She's also a Mandela Washington Fellow and a respected voice on the regional and global child health. In fact, it is affectionately said that if Dr. Boyd were resting on your sick bed and received news that there is a media advocacy event for children, she will promptly dust herself, turn her makeup, and then advocate fiercely for children at the event. They should calmly return to the deathbed. Sick bed, sorry. That is dedication. When she's not shaping children's health systems or mentoring the next generation, she enjoys swimming and spending time with the family. Please join me in giving a warm and well-deserved welcome to the president of the Pediatric Society of Ghana, Dr. Boyd. Yeah.
Good morning, everyone. Can you see my face? Okay, so I will not proceed anymore on that tangent. I was going to wonder whether our podium is friendly and non-discriminatory, but we are here. Okay, so distinguished guests, esteemed colleagues, partners, ladies and gentlemen, it is both an honor and a responsibility to address you at the 2026 AGSM of the Pediatric Society of Ghana. This gathering represents more than a professional forum. It is a shared commitment to the health, dignity, and future of Ghana's children and adolescents. Each year, we reflect on our progress and ask a fundamental question. Are we doing enough for every child? Under this year's theme, Leaving No Child Behind, Advancing Equitable Healthcare for Children and Adolescents with Non-Communicable Diseases, that question is especially urgent. At our 2025 meeting in Accra, we focused on universal health coverage and strengthening resilience in child healthcare delivery. Since then, our society has made meaningful strides. We sustained implementation of the Grand Challenges Canada project, through which over 332 healthcare professionals have been trained in maternal and newborn emergency care. and supported via digital supervision platforms across the Upper West region and the Upper East regions, sorry. We also had the opportunity to finally launch our research mentorship program to build national capacity for pediatric research and evidence-based practice. In partnership with the WHO and Ghana Health Service, we trained healthcare professionals on HPV vaccination, reinforcing prevention as a central pillar of pediatric care. In collaboration also with the International Pediatric Association, we implemented the Immunization Advocacy Champions Project, which helped to extend our impact nationwide. At the heart of these achievements are our members, pediatricians and child health professionals who work tirelessly, often in challenging environments, to advocate for children, their care, and everything around their well-being. Dear members and our partners, your dedication is the foundation of our progress. So thank you. As we now turn our attention to equitable healthcare for children and adolescents with non-communicable diseases, we are guided by a shared vision, a Ghana where every child, regardless of geography, income, or circumstance, has access to timely, high quality, and compassionate care. However, this vision must contend with a sovereign reality. Non-communicable diseases are no longer conditions of adulthood alone. They increasingly shape the health trajectories of children and adolescents globally and in Ghana. Worldwide, we know that NCDs affect over 2.1 billion children and account for nearly 1 million deaths annually among those under 20 years and contribute substantially to disability. Also among adolescents and young people aged 10 to 24 years, NCDs cause almost 39% of deaths, driven by conditions such as obesity, diabetes, cardiovascular disease, chronic respiratory illnesses, and mental health disorders. I could go on and on, but we will have a conference speaker, we'll have a keynote address, so I'll leave some of that for them when it's their turn. As pediatricians and child health professionals, our role extends children in rural and underserved communities face persistent barriers to access, affordability, specialist care, early diagnosis, and follow-up. These inequities are unacceptable. Leaving no child behind requires deliberate action. It demands a commitment to 4 strategic priorities: strengthening primary health care and early detection, enhancing health education and awareness, deepening collaboration with government partners, civil society, and funders, as well as fostering mental health support as an integral component of child health. Ladies and gentlemen, the growing burden of NCDs among children and adolescents is a serious challenge, but also an opportunity for us to reshape systems, influence policy, and secure healthier futures. Before I conclude, may I ask all of us to give ourselves a big round of applause, because as pediatricians, as healthcare professionals who are working in child health care, I have been blown away myself by the commitment and the dedication across the country. So permit me, if you will, to ask you to stand up and celebrate yourselves with a round of applause, a big round of applause. If you have phones, you can feel free to shake them like Prof. Entry is doing that. Thank you all very much. We do not take your support for granted at all. Throughout the year, you have been active and done amazing. God bless you richly. Now back to this. Our mission is clear: Our responsibility is undeniable, and the time for us all to act is now. Ladies and gentlemen, thank you very much and God bless you. Let's enjoy our ATM friend.
Another round of applause for our own indefatigable president of the Pediatric Society of Ghana. We're going to have a documentary. Technical team, are we ready? We're going to have a documentary. Oh, sorry. Okay. So we're going to have a documentary, please. So, technical team. Hello. Kindly, please, those at the back. At the back, please, just come to the front, have a seat so that we can get on with the program, please. So, technical, take it.
No child should be left behind. I'm sure I don't feel sick. Maybe the child has diseases, or maybe they are not feeling well, so they have to rush them to the hospital. So there's a family counseling in that. Value. I bath regularly. I brush my teeth both evening and morning. I eat healthy and balanced meals, and I love fruits and vegetables. The phrase "every child matters" means that all children are equal and should be treated equally, regardless of their background, ethnicity, family's income, where they live. All children need to be prioritized, no matter where they live or who they are. My name is Phoebe. Because being healthy is important because you'll not be able to, if you are sick, you'll not be able to play certain games. You have to be taking medicines. You will not be able to go to school, and you'll not be able to see your friends. Nowadays, parents should be taking care of their children and keeping track of the things they eat. I think it helps me burn my fat and give me body muscles. One way with fish, there's watermelon, apple, banana, orange. So, yes, I believe that all children of Ghana, as well as their parents, should be rest assured that their children are in good hands with medical professionals when necessary. I think the government open hospitals in areas where people are often less privileged and also incorporate outreach programs to meet people where they are and fund public hospitals better. That's things and bits of apples. I think your it's more balanced than that all the certain food groups. And examples are jollof rice with chicken and the side salad or bamboo and okra soup with meat. I will grab the water for them when they need it. I will help them go to the cafeteria, their website to lunch us now. Then I'll inform on their teacher or the teacher so that they can go through. They should go for monthly checkups just to make sure they are feeling healthy and strong.
Because it helps us to stay strong and healthy. Healthy children, healthy Ghana.
That was awesome. I was wondering which school it was. Not like several schools we have. At this point in time, we are expecting some guests. They are not yet here, but we do respect your time, and so we're going to continue. And so she is probably not ready to speak at the moment, but kindly allow me to introduce you. Just use that time to prepare yourself, and then we can continue. So we are privileged to have someone who has 10 conversations to global health security, disease eradication, emergency response leadership, and one name that commands deep respect. Dr. Fiona Bracker. Please, a round of applause. Thank you so much. Thank you so much. Please welcome to that episode.
Good morning. It's always a pleasure for me to engage with the Pediatric Society, so I'm really delighted to be here this morning. Distinguished colleagues, pediatricians, health professionals, ladies and gentlemen, it's my honor on behalf of the World Health Organization to join you at this official opening of the 2025 Annual General and Scientific Conference of the Pediatric Society of Ghana. I want to commend the Society for convening this important forum and for selecting a theme that speaks directly to one of the most pressing, often overlooked challenges in child and adolescent health. The theme, leaving no one behind, advancing equitable healthcare for children and adolescents with non-communicable diseases, resonates deeply with WHO's core mandates and with Ghana's commitment to universal health coverage. It's also aligned with the Sustainable Development Goals, particularly SDG 3, which calls on all of us to ensure healthy lives and promote well-being for all at all ages. Non-communicable diseases are no longer diseases of adulthood alone, as Dr. Hilda said. Globally, over 2 billion children and adolescents under the age of 20 are living with one or more non-communicable disease, including asthma, sickle cell disease, cancers, diabetes, congenital heart disease, epilepsy, and mental health conditions. Every year, nearly 1 million children and adolescents will die from largely preventable or treatable non-communicable diseases, with most of these occurring in low and middle-income countries. In Ghana, as has been said, NCDs now account for approximately 45% of all deaths, and evidence increasingly shows that a significant proportion of adolescent morbidity and mortality is attributable to non-communicable diseases. Childhood cancers, sickle cell disease, asthma, diabetes, epilepsy, and mental health conditions place a large burden on families, the health system, and the future productivity of the nation. For many households, caring for a non-communicable disease leads to catastrophic health expenditure. It leads to disrupted education and to long-term social and economic hardship. With the support of WHO and the St. Jude Hospital in the United States of America, Ghana joined the global platform for access to childhood cancer medicines in 2025, with the first shipment of free medications expected to arrive at the end of this quarter. Yet, the burden of NCDs, it does not fall equally. Children from poorer households, rural and hard-to-reach communities, and those living with disabilities face systemic barriers to early diagnosis, continuous treatment, and quality of care. These inequalities undermine our collective commitment to leave no child behind. Ladies and gentlemen, the origins of NCDs lie early in life. WHO estimates that 80% of adolescents globally are insufficiently physically active. Unhealthy diets are increasingly common, and exposure to harmful marketing of tobacco, alcohol, and underprocessed to ultra-processed foods continues unabated. In Ghana, national surveys show rising levels of physical inactivity, unhealthy diets high in salt and sugar, and early exposure to NCDs among young people. This reality demands, therefore, a life course approach, one that begins before conception, continues through childhood and adolescence, and transitions seamlessly into adult care. So pediatricians, therefore, stand at the front line of NCD prevention, early detection, and long-term management. WHO's evidence is clear. Most childhood and adolescent NCDs are preventable, they are manageable, they are treatable when health systems are strong, inclusive, and equity focused. Allow me to highlight 5 priority action areas grounded in WHO recommendations that are particularly relevant for Ghana. First, we must strengthen primary health care to deliver integrated, people-centered services for children and adolescents with NCDs. This includes early screening, timely diagnosis, referral, and long-term follow-up at the community and district levels. No child should have to travel long distances or face financial hardship to access essential care. Second, we must guarantee uninterrupted access to essential medicines, diagnostics, and technologies, including insulin, inhalers, anti-epileptic medicines, and cancer treatments. WHO strongly advocates for the inclusion of priority childhood NCD services and medicines under national health insurance schemes to protect families from catastrophic expenditure. Third, we must invest in health workforce, particularly pediatricians, family physicians, nurses, and allied health professionals. Continuous professional development in childhood and adolescent NCDs covering clinical management, mental health, palliative care, and transition to adult services is so essential to improving outcomes. Fourth, we must address the social and commercial determinants of health. WHO calls for stronger policies to reduce exposure to alcohol, to tobacco, to sugar-sweetened beverages, unhealthy diets, physical inactivity, and air pollution. Creating healthy school environments, regulating the marketing of unhealthy foods to children, and promoting physical activity are not optional. They are essential public health interventions. And fifth, we must strengthen data and surveillance and research on childhood and adolescent NCDs. Reliable, disaggregated data is essential for planning, for monitoring progress, and for ensuring that vulnerable populations are not left behind. So the Pediatric Society of Ghana has a vital role to play in generating local evidence so that research can be translated into policy and practice. Distinguished participants here, WHO is a committed partner to the government and the people of Ghana. We will continue to support the implementation of the Global Action Plan for Prevention and Control of NCDs, the Global NCD Compacts, the Global Regulatory and Fiscal Compact Capacity Program, RECAP, to promote healthy diet and physical activity, and national strategies that prioritize children and adolescents. We also reaffirm our commitment to working closely with the Ministry of Health and its agencies, the academia, development partners, the Pediatric Society of Ghana, to strengthen equitable NCD care for children and adolescents across the country. As I conclude, let us remember that every child living with a non-communicable disease is first and foremost a child with dreams and potential and the right to survive and to thrive, and therefore leaving no child behind is the measure of the strength of our health system. I wish you the Pediatric Society of Ghana a successful and impactful conference, and I look forward to continuing our partnership in ensuring that the children and adolescents of Ghana thrive to their utmost capacity. Medasi.
Thank you so much, Dr. Fiona Baka, the Country Director for WHO. We are so happy for your presence, and then we thank you for your ever support for Pediatric Society of Ghana. Ladies and gentlemen, please let's put our hands together for a young star in our midst. I'm glad to introduce to you Nanama Boahima Lubo Festuman, a 6-year-old a viral breastfeeding video is appeared on the Ghana Health Service website, and you will catch more of the content on their YouTube channel. Let's give it up once again for Nanama.
Non-communicable diseases are just for grandmas and grandparents. Asthma, diabetes, and sickle cell diseases are crushing our playground funds, and the team says leaving no child behind. But how can we keep up if we can't do or if our bodies are unpaid? To Ghana Health Service, please make sure the medicines reach my friends that not only those in the streets. To our international friends, Keep sending us the Bible so that we can take it from. And of course, don't forget our happy thoughts. Having a sickness is scary, but what you need is a big heart for your heart and our minds. To the adolescents group, how my big brothers and sisters stay cool while staying healthy. Everything means I get what I need and you get what you need, so we can all play together. So let's stop NCDs from being the boss of us. Protect us, treat us, and most importantly, listen to us. Healthcare workers for kids. Thank you. To my senior colleagues, the pediatrician, thank you. My dad asked if the stereotype about pediatricians is true. My answer as for today is indeed sometimes big things come in small packages like myself. Thank you.
Please let's do it again for another. She has made me feel proud. Oh, thank you for making that time to her. Next, we would like to take some messages from our key partners, and we are going to take the first one from the representative from Ghana Health Service in the person of Dr. S.C. Boachekwati. Next, we'll have the one he said in the person of Dr. E. Shramatin Ewa. Please let's give it.
Good morning. Good morning. Saying I'm energized by the knowledge that great things come in small packages, and it reminds me that this medical school, also from the GMA president, that potent medicines normally come in small bottles, and I really feel that too. Also, had to be made an event for the president recently, and I was encouraged that we are one of the best societies among the professionals. Chairperson, if that traditional leaders I saw a chief there, he said, the president of the Pediatric Society of Ghana, that is Dr. Boy, members of the Pediatric Society of Ghana, development partners I see, Dr. Braka, also Red for UNICEF. The media, colleagues, distinguished invited guests, ladies and gentlemen. Once again, good morning. And on behalf of the Director General of the Ghana Health Service, Dr. Sambokaba Korea, who have not been but there is a program ongoing in terms of cancer awareness and the issue. I'm really going to join you as I alluded to earlier on. Because there is energy in the room to join you for your 2026 annual general scientific meeting of your wonderful society. Permit me to begin by commending the Pediatric Society of Ghana for your long-standing commitment to child health and for the invaluable technical contribution your members continue to make to policy reforms, national guidelines, and vision platforms. Your role as a lead advocate for the well-being of the child in Ghana cannot be well emphasized. I think it's obvious to all that they need. We are particularly proud that PSG's digital emergency response projects, which your president alluded to, was selected as one of the top 8 innovations under the Ghana Health Service Country Innovation Platform. I think we deserve a round of applause for that. This PSG project comprises the combined services and digital innovation of both 30 health facilities, primary district hospitals, health centers and polyclinics in the upper East region and upper regions of Ghana has demonstrated your leadership in strengthening quality of care across the continuum of maternal, newborn, and child health. I was then the regional director of Upper East Zone. I was associated with it as director PPM now, those who oversee the issue. The theme for this year's conference, leaving no child behind, advancing equitable health care for children and adolescents with non-communicable disease, is timely, strategic, and strongly aligned with our national priorities. I think Dr. Chiro said yes, and currently two major government flagship initiatives. I'm sure you are all aware of the free primary health care, Ghana Medical Trust Fund, also done the Mama case. The free primary health care aims to broaden and finance promotive and preventive services at the sub-citizen level. The Ghana Medical Trust Fund or the Mama case seek to reduce catastrophic expenditure and expand access to quality essential services for chronic and non-communicable diseases. And I think when the 5 pillars were said by the leader speaker, these were included. Indeed, the team reflects.
You want us to finish cutting the ones that have
His Excellency the President, ensuring that every Ghanaian, especially our dear children and adolescents, living in NCTs, receive timely, affordable, like without any financial decision. NCTs now account for 40-45% of all this in Ghana. I'm sure you guys are not the statistics, so I won't go into it. Childhood asthma, sickle cell disease, epilepsy, obesity, congenital health conditions, diabetes, and mental health conditions, increasingly emerging. These trends require a life-force approach, grounded in empathy, early detection, and continuity of care. Principles firmly emphasized in Ghana's NCD policy, which I'm sure most of you will be familiar with. The Ghana Health Service is therefore strengthening primary health care readiness for chronic conditions. As you know already, when you go to our chips, if you know the chips, community based compliance services, go to home visits, outreaches. When they go, they check all these things. But I won't talk about the pediatric population. So while full integration of pediatrics with SCDs screening to routine chip services are still evolving, we have begun gradually into general SCD screening at chips level during home visits, as I said, routine community and outreaches, and our school health programs. These early steps will provide a way for more structured integration of child and adolescent services in the coming years. Additionally, the Ministry of Health recently launched the sickle cell disease screening and case management guidelines, and that will help expand newborn screening and standardized national care pathways.
I also think this one, before we cut, we have to cut it here.
Both physical
This one.
activity and healthier school environments.
Cut this one off first, so that when you're pulling, it doesn't dislodge the other one.
Goals.
No, we're going to cut it right to the bottom. I don't want it to grow again. So
Children will address issues of overweight and obesity, which is on the right. A challenge highlighted in Ghana's sensitive policy. Yet we must also be candid about the challenges. That's right, the modest things. Supply chain gaps continue to disrupt the availability of essential SCD medicines and diagnostics. And Ghana faces a critical shortage of pediatric specialists in endocrinology, urology, cardiology, and oncology. Like I said, recently I was in Upper East Region, and having a specialist, even two of them, I remember Dr. Budi and Beta, I don't know whether they are here. It made a big difference when it came to pediatric care in the northern part of the country. Which means that much as we know there may be challenges, it's important that some of you may have to find yourself there, but we need to support you to be there. Low awareness and hard to reach communities leads to delayed care, stigma, and avoidable complications. Addressing this requires collective action, strengthening primary care readiness for pediatric NCDs, expanding specialist training, ensuring reliable access to essential medicines, improving data for decision making, and intensifying community and school level education. Strong collaboration among the Pediatric Society of Ghana, Ghana Health Service, National Insurance Authority, and academia, and other NGOs and the movement partner like the WHO, UNICEF, will be vital to drive the diversity change. This conference must therefore become a decisive catalyst for national action. And I really encourage you. A member of the Ghana Medical Association, I think the PSD show a very formidable force. I'm sure that at the end of this conference, there should be a call to action. Driving forward early detection, strengthening primary care capacity, expanding specialist training, reinforcing supply chain, and improving data visibility and deepening community awareness across the whole of the country, especially in our districts and South District. Together, we can transform these priorities into measurable progress. Let me reaffirm on behalf of the Director General that the Ghana Health Service stands solidly with the Pediatric Society of Ghana. Your leadership, expertise, and advocacy remain central to our shared mission of delivering equitable, high-quality health services for every child in this country, irrespective of where the child finds himself or himself. Once again, on behalf of my board, the Director General, I send our full commitment to wish you a productive, inspiring, and powerful conference. Thank you, and God bless you all.
Dr. S.K. Wachibwate is the director for PBME, and he is representing the Director General for the Ghana Health Service. Please let's give him a round of applause. Thank you so much. Next, we have a message from UNICEF, who is also one of our key sponsors. Let's invite to the podium Dr. E. Tremate Ewa.
Thank you. Thank you, Madam MC. The name is Timothy Kamwai. It's great to be here, bringing you greetings from UNICEF, from my chief, Dr. Juan Andoti West, who was actually coming. We had planned this together. So he had a call to be at the ministry this morning, the minister on the free healthcare program and briefing GPs. So I stand here to give a few remarks towards this very important meeting. So, good morning, distinguished guests, dear colleagues, dear development partners, Dr. Fiona from WHO, other partners here in Ghana, traditional leaders, ladies and gentlemen, the media, and all protocol duly observed. UNICEF is pleased and very happy to be associated with the Pediatric Society of Ghana as it marks its 2026 AGSM on advancing equitable healthcare for children and adolescents with non-communicable diseases. Previous speakers has already alluded to the timeliness of this and given a lot of statistics when it comes to the common NCDs that children and adolescents face. So let me not inundate you again with all the statistics. But the evidence is clear that now we stand on the threshold where traditionally, as low and middle income countries like Ghana have been battling infectious diseases, now we have a double tier where we also have to pay attention to the long-standing chronic non-communicable diseases that is stealing the potential and future of our children and adolescents at a very early stages. The PSG has shown that it is not only interested in clinical care and providing quality healthcare in their clinics and in our hospitals, but has also shown that it is interested in advancing the formation and advancing, importantly, the determinants of health that impacts children in many, many ways. I was privileged yesterday to be part of the pre-conference on environmental health and on stopping illegal mining, and it was such an eye-opening conversation and with a lot of insights and thoughts, a lot of research that has been done that converges the evidence that there is no longer time to sit on the fence, but it is time to join efforts to advocate for a healthier and a safer environment for our children to grow and to thrive in them. Ladies and gentlemen, it is important to know that, or to be reminded again, that looking at the determinants of health, there are several which has been mentioned, from the playground of the children to food, the quality of food that we are eating. Yesterday, one of the presentations from CSIR mentioned that you would give the child the protein, you would give the child the maize, but does the protein deliver what it's supposed to deliver to the child? Meaning that you may give that food portion, but the actual value has decreased because of all the changing climatic and other factors that are impacting food quality. And if our foods are being impacted, where do we even begin from? Because that is all that we have. These and many other conversations, ladies and gentlemen, brings us to the fore on also looking at the determinants that drive children and adolescents into the non-communicable diseases. But we know that the PCG has also, the ESG has also strategically placed itself as a chief advocate for ensuring that governments and partners come on board and ensure that children's well-being is being undertaken. Permit me to mention a few of the things that UNICEF is doing when it comes to advancing children's well-being on these non-communicable diseases. As we've seen, one of them is on nutrition, and we have programs in our schools where children are being encouraged to eat a lot of fruits and vegetables to bring them to school and actually show. There are also programs on ensuring that our school environment is healthy. If children want to take a snack, what choices do they have on the compound? What beverages are they taking? What availabilities are before them to take? These and many others also on the environment. And critically, now that evidence is showing that we have some of the chemicals that are endocrine disruptors, the endocrine disrupting chemicals that have the ability to change the hormonal and the endocrine response of our young ones to the environment, leading to diabetes, leading to cancers and other non-communicable diseases. And these we are doing advancing evidence generation and pushing the frontiers together with government and other partners to ensure that children receive the best care. We continue to encourage the PSG to be a strong advocate. Your voice is very strong and your voice echoes in many places because you are in the consulting rooms, you see the cases firsthand, and so you have the evidence to put out there. We encourage more research, we encourage more evidence generation to shape policy as been alluded by other speakers, so that Ghana will provide the safe environment and the quality clinical care for our young ones. We wish this conference well and hope that we'll leave here with a clear roadmap to strengthen our advocacy and ensuring that no child is left behind. And indeed, at UNICEF, as you can see, it is UNICEF for every child. So we leave no child behind, for every child deserves good health, every child deserves to thrive in a safe environment, every child deserves to live to achieve their full potential. We wish you well and hope you have an impactful conference. Thank you.
I want to say a big thank you to our representative from the UNICEF for that message. Ladies and gentlemen, after hearing such words, we want to listen to another bright and inspiring young leader from the Pentecost in ES9, which is PSS3. She's already making remarkable news in advocacy, media, and creative arts. She serves as Child Youth Ambassador with the Eastern Regional Youth Council to champion, using her voice to champion harmony, unity, and positive social change. She's also a news actor, active panelist on Future Leadership Program on Sunrise 106.7. Beyond advocacy and broadcasting, she's a gifted spoken word artist who has graced several platforms, including Celebrant Corporation and Gospel International Church here in Cove Town. Within her school community, she continues to nurture her passion for poetry, using creative arts as a powerful tool for expression. Ladies and gentlemen, please join me in warmly welcoming Inshira Tiwa Frimpong to the stage.
Listen to me. I am a child. But my body learned sickness early. Before I learned to ride my bicycle, I learned the smell of hospitals. Before I learned to read my times tables, I learned how to swallow my pills. They tell me healthcare is a right, but right feels far. When the medicine is far, when the medicines are costly, when my mother can't find a closest coverage. Leaving no child behind. Does that include me? The child in the village, the child in the city slum, the adolescent who hides inside like a secret, the teenager who pretends to be strong because stigma hurts than needles. Equity is when you see me, that's just my disease. It is when you reach me, not just the statistics. It is when you bring care closer, make treatment kinder, and let hope live longer. I do not ask for a special treatment, but a fair chance. A chance to breathe freely, to live boldly, and to learn fully. Leaving no child behind. When we say that, say it slowly, say it truthfully, say it with action. Slowly at first, but together. Hold my hands, don't let me fall. See my need and hear my call. For in the end, my hope will rise. No child behind, we all move. But listen to my humble cry and plea. Stop saying. Stop destroying our water bodies. Stop destroying our environment. Stop polluting our land. Stop destroying the future of our youth. We must care for them. Our children are distracted because of galamseys. Their hope has been destroyed because of illegal mining. Where are all our feelings? They can't just disappear. If the earth has a mouth, she will speak. Leaving no child behind. We must care for our children and the youth. They are our future leaders. And in Ghana's land where gold flows free, children suffer in their future's tragedy. Their smiles fade in the mining storm. Their smiles fade in the miner's storm. Their smiles fade in the miner's storm. What are all our feelings? We are human beings. Listen, when you do something bad for someone, the same thing happens to you. It's like a cycle. When you're polluting our water bodies, remember, you'll be the same person to drink from that water. Women weep because they are giving birth to disabled children. Where are all our feelings? They weep because their children are born disabled, not because they did it themselves, but because of you and I. Where are we? We can't just sit there for other people to destroy our water bodies. We must rise. Ghana must rise. We can be bold, and our boldness can fight it. Let us come back in unity. Let us unite in peace, for we are one people, one country, and one nation. The world is for us, and we are for the world. We shouldn't let other people destroy it. We are living in the same world, destroying it ourselves. Why are we doing that to our own? Children, innocent children, are born disabled, all because of our negative activities. We must come together as one nation and fight against Galamsey. Galamsey is destroying us. Galamsey is making a lot of children disabled. Why? Why? Why are we doing this to our own selves? Mothers are crying. Their bellies are crying. All because of us. All because of our negative activities. All because of our careless activities. So with my humble plea, let us come together and help stop Galamsey. Because united we stand, divided we fall. Cry away, but you back one people. Couple was one thing. It is ensure the future projection that I have.
President, I think you have your note. You do your advocacy very well. Now we're going to have some solidarity messages from some of our brothers, sisters. Pediatric Society of Ghana does not work in isolation, it works with other societies. And the umbrella one that we work with is the Ghana Medical Association. And so we'll have 2 minutes of solidarity messages from the Ghana Medical Association from Dr. Abigail Saki. Dr. Abigail Saki, thank you. A round of applause.
Hello, good morning. I'm the Vice Chairperson of the GA Legal Commission, and I'll be reading this on behalf of National President of the Pediatric Society of Ghana, distinguished guest partners, police. On behalf of the President of the Ghana Medical Association, I'm honored to convey our solidarity and strong support to the Pediatric Society of Ghana on the occasion annual and scientific meeting. We commend the Society for its consistent leadership in advancing evidence-based discourse and advocacy for the health and well-being of children and adolescents in Ghana. The conference theme, Leaving No Child Behind, resonates deeply with our collective professional and moral responsibility. Across the country, children living with asthma, diabetes, sickle cell disease, epilepsy, neurodevelopmental, and mental health conditions continue to face challenges shaped not only by clinical care, but by the inequities in access, continuity of care, and social protection. Too often, geography, poverty, and system limitations influence outcomes more than clinical need. From a national perspective, persistent gaps remain in early detection, referral systems, continuity of care, integration of mental health services, and access to specialized pediatric services. particularly at the primary healthcare level. Addressing these challenges require deliberate policy coherence, sustainable health financing, workforce development, and strong multi-sectorial collaboration beyond the health sector. As healthcare providers, we witness both the resilience of children and adolescents and the struggles of families navigating long distances, fragmented services, and limited resources. These realities reaffirm that equity in children's health is not optional. It is central to our duty as health professionals and to the pursuit of universal health coverage. The Ghana Medical Association reaffirms its commitment to working closely with the Pediatric Society of Ghana and all stakeholders to advocate for policies and investments that strengthen universal health care, prioritize prevention across the life course, and ensure that children and adolescents, particularly living with non-communicable diseases, are fully integrated into national health strategies. We are confident that the scientific deliberations and policy engagement at the meeting will generate practical, actionable recommendations to inform planning, resource allocation, and implementation at all levels of the health system. We wish the Pediatric Society of Ghana a successful and impactful annual general and scientific meeting and look forward to continued collaboration in advancing equitable, high-quality healthcare for every child and adolescent in Ghana. Thank you.
Wow, exactly 2 minutes. And she said a lot. We're grateful to the Ghana Medical Association. Next, we're going to have our sisters and brothers from the Ghana Registered Nurses Midwifery Association of Ghana. We would have Edwina Adika Benson, please, with a solidarity message. You don't look like an Edwina. Oh, Wayne, I am so sorry.
You are forgiven. Good morning, everyone. The president, the executives, distinguished members of the Pediatric Society of Ghana, honored guests, colleagues, ladies and gentlemen. I bring you warm fraternal greetings from the Ghana Registered Nurses and Midwives Association. We bring you our solidarity, respect, and deep appreciation for the vital work you continue to do for children and adolescents across our country. Your theme, Leaving No Child Behind, advancing equitable healthcare for children and adolescents with non-communicable diseases, speaks directly to one of the most urgent health challenges of our time. Non-communicable diseases among children are no longer rare stories in textbooks. They are now part of daily reality in our various clinics, schools, and communities. Asthma, diabetes, sickle cell, childhood cancers, and other chronic diseases demand long-term, coordinated, and compassionate care. Equity in this context means early detection, continuous treatment, strong referral systems, family education, financial protection through responsive health policies. This is where nurses and midwives stand firmly with you. Across Ghana, nurses and midwives are often the first point of contact for children and their family. We lead in health promotion, school health services, early screening, chronic disease management, counseling, and community follow-up. We are also advocates speaking up for policies that protect vulnerable children through NHIS coverage and expand preventive services. The GRNMA remains committed to working with the Pediatric Society of Ghana and all other partners to strengthen multidisciplinary care, improve caregiver education, and build a health system where no child is overlooked because of where they live, their background, or the condition they carry. It is our firm belief that together we can shift the narrative from late presentation and preventable complications to early action, sustained support, and healthier future for Ghana's children. On behalf of the President and Executive of the GRNMA, we wish you a successful and impactful annual general and scientific meeting. Have a fruitful discussion. Thank you.
And a round of applause to Edwin. At this point in time, we want to hear from the Pediatric Society of Ghana Eastern Region Chairperson, in the person of Dr. Asibe. She'll give us a few words and then we will continue, please. So let's welcome Dr. Asibe.
Morning, everyone, and welcome to the city of, or the, I would say the town of beautiful flowers. Distinguished guests, I hope my speech is also going to be very pediatric. Distinguished guests, honorable representatives of government and partner institutions, policymakers, national and branch executives of the Pediatric Society, advocates for child health, esteemed colleagues, ladies and gentlemen. I'm giving this speech on behalf of the local organizing committee that have been through a lot to put this program together with the support of the National Executive Committee. It is my great honor to welcome you to Koforidua to the 2026 Annual General and Scientific Meeting convened under the theme Leaving No Child Behind, Advancing Equitable Care for Children and Adolescents with Non-Communicable Disease. We are grateful for your presence and continued commitment to improving the health of children and young people. This meeting provides an important platform for scientific exchange, collaboration, and reflection, which I think a lot of us got from the pre-conference. We extend our sincere gratitude to our cherished sponsors for their generous support and partnership that has made this program a huge success. We also wish to acknowledge and thank our media partners for their role in amplifying the voice and the outcomes of the scientific conference. Through your timely coverage, we know that the key messages and resolutions will reach a wider audience beyond this platform. The local organizing committee expresses its profound appreciation to the national executive. I want us to give a big clap to the executive committee who have been a great support to the organization. We extend special appreciation to Team Eastern Region for their dedication, professionalism, and talent effort to put this program together. The society here actually has just about 10 members, so it really hasn't been very easy. Your teamwork, resilience, and attention to detail ensures smooth coordination on the ground. I also like to take this opportunity to acknowledge and commend every member of the organizing committee for their efforts. I also like to emphasize that the members of the LOC remain really available through the conference. They are fully prepared and more than willing to assist you with the needs and concerns that will arise. And after all these productive deliberations, you are free to tour the region. We have the safari at not so far, about 30 Aqua Safari
with the Safari Valley, so about 30 minutes from Koforidia and other interesting places to visit. Thank you so much. Akwaaba.
Thank you, Dr. Asube. Another round of applause to our fellow teams here. We've been sitting for a long time, isn't it? So we're gonna do a quick tour of our poster presentations. We know that some of you are so busy, we want to probably lunch, right after lunch, you'll probably be heading out to Accra, wherever. So let's use this opportunity to just have a quick tour, just a few minutes to look at the poster presentations that many of our colleagues have put up. I think that would give us some time to stretch. Or you want us to do stretching exercise now? Should we do stretching exercise? So let's be upstanding, just take a walk, and then I'll call you in. I'll call not. You can take a quick break in terms of a bathroom break, but I'll call you in just about 10 minutes, please. So the poster presentations are at the back, please. Thank you. Just look around, take pictures, put it on social media.
No, Mr. Wait, it's not about. I'm Mr. Wait, it's not about. Two. Yeah. Really? Really? Really?
I see that everyone is awake now. I think it was a good time. We did get to see presentations, poster presentations. We do have to continue though. There will be a snack break after our keynote speaker addresses us. There will be a snack break, and you have another opportunity to have a look at the posters, and the judges would also use that opportunity to judge the posters. We're going to continue with our solidarity messages, and we're going to have SOGOG, the Society of Gynecology and Obstetricians Ghana, in the person of Dr. Francis Woba, giving us a solidarity message, please. Thank you.
Thank you so much. Good morning to you all. So this is a solidarity message from the president of the Society of Obstetricians and Gynecologists of Ghana to the Pediatric Society of Ghana. I am merely the messenger. All good things in this message belongs to my boss. If you are offended by anything, I will take responsibility for that one. Distinguished presidents and executives of the Pediatric Society of Ghana, esteemed colleagues, honored guests, ladies and gentlemen. On behalf of the Society of Obstetricians and Gynecologists of Ghana, and in my capacity as president, it is my great honor and privilege to bring you warm greetings and heartfelt solidarity on the occasion of your annual general and scientific meeting. We commend the Pediatric Society of Ghana for convening this important gathering under the timely and deeply relevant theme, Leaving No Child Behind, Advancing Equitable Healthcare for Children and Adolescents with Non-Communicable Diseases. This theme speaks not only to clinical excellence, but also to justice, equity, and the moral responsibility we all share as healthcare professionals. As obstetricians and gynecologists, we are very much aware that the foundations of child and adolescent health are laid long before birth, beginning with maternal health, nutrition, antenatal care, and safe delivery. The life course of non-communicable diseases often starts early, sometimes even in utero, influenced by maternal conditions such as diabetes, hypertension, obesity, malnutrition, and environmental exposures. In this regard, the work of pediatricians and obstetricians is not separate, but deeply interconnected. We are partners across the continuum of care, from preconception and pregnancy through infancy, childhood and adolescence, and into adulthood. Non-communicable diseases among children and adolescents, including asthma, diabetes, sickle cell disease, congenital anomalies, childhood cancers, and mental health conditions, present a growing challenge in Ghana and across sub-Saharan Africa. These conditions often require long-term care, multidisciplinary collaboration, and sustained family and health system supports. Yet, as your team rightly highlights, equity remains a critical challenge. Far too many children and adolescents living with NCDs face barriers related to geography, poverty, gender, disability, and limited access to sophisticated services. Leaving no child behind must therefore move beyond rhetoric and translate into policy action, system strengthening, and collective advocacy. The Society of Obstetricians and Gynecologists of Ghana stands firmly with the Pediatric Society of Ghana in advocating for stronger integration of maternal, newborn, child, and adolescent health services, early prevention and screening strategies, beginning in pregnancy and early childhood, improved referral systems, and continuity of care,
investment in specialist training, research, and data for childhood and adolescent NCDs. And above all, a health system that places the child and the family at the center of care. We also recognize the critical role of adolescents, particularly adolescent girls, whose health outcomes are shaped by early life experiences and whose well-being directly influence the next generation. Addressing adolescent NCDs, reproductive health, mental health, and nutrition is therefore a shared priority for our two societies. Colleagues, the challenges we face are complex, but they are not insurmountable. When professional bodies speak with a united voice, grounded in evidence and compassion, we can influence policy, mobilize resources, and shape a healthier future for Ghana's children. On this occasion, SOGOG reaffirms its commitment to continued collaboration with people in clinical care, training, research, and advocacy. We believe that together, we can strengthen the continuum of care and ensure that no child, regardless of circumstances, is denied the opportunity to live healthy and fulfilling life. I congratulate the Pediatric Society of Ghana on another successful AGSM. I wish you fruitful deliberations, meaningful outcomes, and renewed strength as you continue your vital work for the children of our nation. Please accept our warmest solidarity. Best wishes. Thank you.
Thank you. And we're also going to have another solidarity message from the Union of African National Pediatric Societies and Association. We are pleased to welcome our past president of the Pediatric Society of Ghana in the person of Dr. John Adebi Appiah to give us a solidarity message.
Good morning. I present this message on behalf of the president of Union of National African Pediatric Associations and Societies. As the president-elect, the next 2 years I'll be taking over from him when we meet in Rwanda this year. However, taking cue from the immediate past speaker, all good things must be alluded to him, and then the bad place you can see me to resolve it here and don't take it away from here. Person, the National House of Chief Representatives or the representative of the Chief Fancy here, Madam President, and then past President Prof. Goga. We also acknowledge the presence of special guests, WHO's representative, UNICEF, and then others, and Ministry of Health here. Greetings from my president, John Gordy from Central African Republic. We are pleased to be invited here to join you to celebrate this day as part of your activities to highlight the importance of pediatrics and child health on the continent. His message is that UNAPSA was formed as a forum which was necessitated for African pediatricians at the continental level to help put together, to exchange ideas, to share our experiences to improve child health. We aim to do and promote the highest attainable standards for all children across the sub-Saharan part of Africa. And our vision is to optimize child survival and development. So your theme, leaving no child behind, applicable healthcare for children and adolescents with non-communicable diseases actually resonates very well with our key objectives that we promoted. We acknowledge also that there are changing epidemiology, and then additionally, there are children who on the continent are also suffering from non-communicable diseases and conditions that we pay very little attention to. So it's heartwarming that as a member of UNAPSA, Pediatric Society is taking lead in this area. We want to inform you that members actually recognize the significant role that played in the formation of the association in 1970, 1980, the role that you played. We have a couple of presidents from our president. Presidents were Ghanaians, and they discharged themselves very well. It is our hope that this conference is highly successful and that we await your resolutions, your shared experiences, and then practices, best practices to help guide us in. Please, can you rise? Can we please be upstanding? So thank you very much for this short break. And then, so we hopefully await your resolutions and then shared experiences in terms of best practices to guide other member states. The consensus among the member states is that Ghana is a beacon to UNAPSA. You have led in several areas, and we continue to share and partake in everything you do. Thank you very much. We welcome Nana and then the Honorable Regional Minister in our midst. At the appropriate time, we will duly acknowledge you appropriately. So please, thank you very much. I will quickly end my speech so that the right thing be done. Yeah, so however, before I do that, we share the same principles. We are looking forward to strengthen our workforce, improve the pediatric patient ratio, that pediatric nursing specialist patient ratio to be able to deliver. Specialization is an area where we look forward to. Several patients are lacking the needed support. And if you are talking about leaving no patient behind, we move beyond the statistic and look at individual patients. So that is what pediatricians we do. We acknowledge also the fact that, and we believe in the fact that since you have chosen this as pediatricians, you know what to do with milligrams per kg for every drug dose. You don't lump all of them in one basket. And we believe that we are going to do that. Unfortunately, we lost one of our stalwarts this year, that is Professor Angela Okolo, our historian. However, our message is that as we see the vibrant young pediatric population here, we believe that we have enough people to fill in the space to develop child health in Africa. Again, we look forward to strengthening the cordial relationship that exists between UNAPSA and also provide the necessary support. Thank you very much.
Ladies and gentlemen, Dr. David is the president-elect of UNAPSA. Please let's give it up for him again. Distinguished ladies and gentlemen, it would have been a great honor to receive in person His Royal Majesty Dasebre Kweku Boateng III, the paramount chief of the New Jobing traditional area, a revered custodian of tradition, a distinguished leader, and an accomplished global entrepreneur whose influence spans cultural stewardship, international business, and national development. Unfortunately, due to present traditional and state responsibilities, he is unable to join us in person today. However, in keeping with the dignity and continuity of traditional leadership, he has graciously delegated representation to a worthy emissary from his traditional council. It is therefore my privilege to present his delegated sub-chief, Nana Kofi Ejapon, the Abrafo of the New Javan Traditional Council, joining us today on behalf of Dasire with Legend. Please join me in extending the same warm respect and honor as we welcome Nana Kofi Ejapon, Abrafo of the New Javan Traditional Council. The Abrafo, sorry. Abrafo.
Thank you. Good morning, distinguished chairpersons, additional authorities, esteemed health professionals, researchers, partners, ladies and gentlemen. My name is Nana Kofi Ejapon, and I thank you for having me here this morning as a special guest. So I'm not here on my own, here simply as a representative to Dasire Kwekubuatin III. So I'd like to thank you all for coming. What I have to say is that I'm humbly honored to be here. And also, I'd like to thank the Pediatric Society of Ghana for such a great event to help the people of the Eastern region. What moves me the most this morning is a theme which says, leaving no child patient behind. For me, I believe that what we have as hope, as a people, is the generation that comes after us. So I'm glad that at least we are recognizing them as a priority and trying to put all these things in place to protect and secure their future. Thank you very much.
Thank you so much, Nana. We are very glad to have you here. Next, I'm going to introduce a woman of ambience. So this person we are going to introduce is a governance powerhouse whose resume reads like a masterclass in leadership, education, and community transformation. The Eastern Regional Minister began her journey as a social worker and steadily climbed the ranks of local governance, making history as the first female presiding member of the Ilokobo Municipal Assembly armed with academic credentials in political science, leadership, and a PhD pursuit in migration studies. She passionately advocates for inclusive governance and women's empowerment. Alongside steering regional development, she runs an NGO championing women's causes and directs an educational institution, proving she has fully embraced the art of multitasking at Olympic level. Ladies and gentlemen, with a standing ovation, please join me welcome Honorable Rita Akosia Eche Awate, the Regional Minister for the State. In fact, this introduction, I don't know, I'll try and do something. Please, don't expect much. Thank you. Rep of the Sibre Kwekubuatin the church, Omahinin of New Draben Traditional Area, and President of the New Draben Traditional Council. Nananum here present. Rep of Nana Oredu, the first founder of Kabaka Foundation. Our Member of Parliament of New Draben South, if here present. Regional Director of the Health Service, Medical Director, Eastern Regional Hospital, our esteemed health professionals, our researchers here present, our development partners, stakeholders, distinguished guests, the media, ladies and gentlemen, a very good morning and a welcome to a very beautiful part of the East. I am truly delighted to be the guest of honor at this Pediatric Society of Ghana's 2026 Annual General and Scientific Meeting. It is a great privilege for me as a proud daughter of this beautiful region to host such a distinguished gathering of great professionals and stakeholders whose work touch the very lives of our children and families across our region and country. Once again, you are welcome. Please, your presence here affirms the Eastern region's growing role as a hub for thoughtful dialogue, learning, and national development. We are grateful you are here to engage in an all-important national conversation on child and adolescent health. I can see my personal doctor looking straight into my eyes. Dr. Uba, I want the whole world to know that you are my doctor. We thank you for traveling from far and near, and we hope that during your stay, you will experience the warmth of our people and the strength of our shared purpose. This occasion is particularly meaningful to me as a regional minister because public service offers many moments of responsibility and moments of honor such as this, where leadership, science, compassion, and national purpose intersect. It's a good one. Congratulations to the Pediatric Society of Ghana on putting together this very beautiful meeting. Nananom, distinguished guests present. The theme for this year's meeting is both timely and compelling. Leaving no child behind, advancing equitable healthcare for children and adolescents with non-communicable disease speaks to the very heart of equity. It speaks to fairness. It speaks to justice. It challenges us to look beyond systems and policies and also to focus on children, families, and communities. While these deliberations will explore important scientific and professional dimensions, I wish to highlight the broader message of inclusion and equity that this theme carries. It is a reminder that progress is incomplete if it does not reach the most vulnerable, and that national development must be measured by how well safeguard the future of our children across the country is. As we reflect on today's discussion, let us be reminded that awareness alone is not enough. The true measure of our commitment will be seen in the action we take after we leave this room. Let us leave here with a shared resolve to move from dialogue to output delivery, from intentions to impact. We work together with purpose and accountability. We can build a future where every child, regardless of background or location, has the opportunity to live a healthy and fulfilling life. The Eastern region is home to diverse communities, to urban, peri-urban, rural, and each with unique strengths and challenges. Hosting this annual general and scientific meeting here creates opportunity for shared learning and collaborations, and for translating ideas discussed in this room into meaningful impacts within our communities. I hope that you will make time to enjoy the beautiful tourist sites in our beautiful region. I will want you to go around after this program to visit the Brown Hills, to go around Ebri, to go see the Boutique Falls while you are here. Ladies and gentlemen, as the minister in charge of this beautiful region, I remain committed to supporting initiatives that promote child welfare, social inclusion, and equitable access to services. I also commend all participants for your passion, professionalism, and service to our nation. May your discussions be so enriching, your collaborations so productive, and may your time in the Eastern region be a fruitful and memorable one. Thank you for the honor, and once again, I warmly welcome all of you. May God bless our homeland, Ghana. May God bless our beautiful region, and may God bless your society. Thank you.
Another round of applause to our regional minister. I think that 2 years time we should come back here to Eastern region. I'd like to make a few acknowledgements. Our special guest in the person of the Eastern Regional Minister, we're grateful to have you. Our representative, Paramount Chief Dasupre II, we welcome you. Our representatives from the Ghana Health Service, the representative of the Director General, we welcome you. Want to welcome our those who offered solidarity messages, SOGOG, GMA, GRNMA. We are grateful. Want to also recognize our key partners. Again, I will start with WHO, our country director, Dr. Fiona Braka, our ministry, the Ministry of Health, Ghana Health Service, UNICEF, Nebraska, University of Nebraska, thank you for coming. And our sponsors, let's give a round of applause to our sponsors. As the little girl said, we want your kudi, and they did provide. MSD, AHS, Panacea, GIZ, Reload, Ethifarm, Unicom, Indus, IBA, Zifam, Tridem, Cipla, Kabaka Foundation, Pharma Symbiosis, Eastern Premier Hotel, Bliss GBS Pharma, Kesiwa Beauty Supplies. Let's give them a round of applause. We also want to thank our media. Without the media, the fourth state, GTV, TV3, Joy News, UTV, Graphic, Adum FM, Sunrise, and GNA. We are grateful that you are going to raise the awareness that we're trying to create to the entire nation and beyond. I want to take this opportunity to welcome again our president to give some closing remarks. Let's give a round of applause to our president, please.
Nananam, the Honorable Minister of the Eastern Region, distinguished partners, distinguished invited guests, distinguished ladies and gentlemen. I think we've had a beautiful morning, but we cannot close the opening ceremony without displaying our red armband. How many of us have them on? Good. Is there anyone who would want to tell me why they have it on? Dr. Nellie Day. She was honored by the Queen of England, distinguished pediatrician who has worked many years in community pediatrics. Shall I come to you?
Hello, I was not expecting this at all. Yes, we are wearing this red armband to bring awareness of Galamsey to Ghana and the world, actually. Yesterday, we had a very good discussion on what Galamsey is doing to our country. And the Pediatric Society of Ghana is behind putting it right. It will take a long time, but yes, we back you. And I think it should be a legacy of our generation that we have recognized the ill effects of Galamsey on our population, which is going to go on for the next 15 years if we don't stop it now. So please wear your red armband, and if anybody asks you why you're wearing it, tell it why. Thank you.
No one else could have done it better than her. That's why I called her out. So we've had, just to say, today is like the icing on the cake to highlight the whole thing. Yesterday, we had the children and environmental health track, and so we discussed this extensively. The Eastern region, unfortunately, is also one of the hotspots for Galamsey in Ghana, and we are honored to have our Honorable Minister here, who is also very close to the president. What a better way to send our message. Okay, so we hope that it will be highlighted, and we hope that you will all join in the advocacy. So thank you all very much for making time to be here and to be part of this opening ceremony, part of our AGSM for 2026. God bless you. Okay. Okay. Thank you. So please, just before we close, so we have some
awards and citations. That will be at the later part of the program, but we have 3 people who might not be here at the end of the day, so would like to go ahead. So please, we call Dr. Henry Labi here. Mr. Henry Labi, please, are you here? Yes, Dr. Henry Labi, yes.
Dr. Henry Labi is standing in for the CEO of Kabaka Foundation, and his citation reads, "The Pediatric Society of Ghana appreciates your philanthropic efforts and your commitment to the care of children in Ghana. Nana, through the Kabaka Foundation, has fully funded and donated several educational development projects, including a 50-seater innovation lab and e-library for St. Peter's SHS, PESCO, and scholarships for brilliant but needy students, among others. The Pediatric Society of Ghana celebrates you and is grateful for your dedication to the welfare of children in Ghana. Nana, Onyamin Shrao, Ayiko." To do this honor, shall we humbly invite the Regional Minister to hand over the citation to Dr. Henry Labi on behalf of Nana Oredu Wadlo. Honorable Minister, it will excite you to know that if you come to the Eastern Regional Hospital, Nana Oredu Wade has also put up, together with Kabaka Foundation, has put up an ultra-modern NICU you would love to see.
Thank you so much. Please, a round of applause for ourselves again. We will present this citation of honor to Mr. Alberto Mario Noretti. This is in recognition of his dedication and commitment to child health advocacy in Ghana, and the Pediatric Society of Ghana salutes you, Mr. Albert Mario Noretti. And we present this citation to celebrate your career as a journalist. So, journalists, they don't want to be spoken about, but they like writing a lot. Please let me finish. Your career as a journalist has impacted public awareness and policy discourse on children's health. And for all this, your bold reporting, which spans critical topics, including newborn jaundice, childhood cancers, and road safety. Indeed, you have championed campaigns against child marriages and have advocated for children in Ghana and in the Volta region in particular. Ladies and gentlemen, Mr. Alberto Mario Noretti. Ayiko. A round of applause, please. Our next citation of honor goes to the Honorable Member of Parliament for New Joabin South in the Eastern region. It is with great honor and admiration that the Pediatric Society of Ghana celebrates you for your support and remarkable commitment to care of children. Indeed, you've supported and fully funded the cost of care for numerous newborns, children, and mothers at the Eastern Regional Hospital and several other health facilities.
The Pediatric Society of Ghana is grateful for your dedication to the health and well-being of children in Ghana. We say Ayiko. And this goes to Honorable Michael Otri Baby. Thank you so much. A round of applause, a round of applause. Thank you so much, Regional Minister. Thank you. A round of applause, a round of applause, a round of applause. We'll kindly invite on the podium Professor Beidu. Please, a round of applause for him. A round of applause, please. Right, so we are presenting this honorary membership award to Dr. Thelma Brown in recognition of her dedicated service to the children of Ghana. And to receive this award on her behalf is our own LOC chair, so she sends us her apologies. She's not in the country. Prof, please, you'd help us with this next one. And this is to celebrate, and this is an award from the Pediatric Society of Ghana, celebrating education and training. And this is presented to a man who is distinguished in this field and is in recognition of his outstanding impact on pediatric education in Ghana. As you can see, this is a very, very summarized version, because if you get to know the person, you would understand. And we present this to Dr. Emmanuel Abekwe Pavi. Please, a round of applause. A round of applause, please. A round of applause. Congratulations. Right. So we invite on the podium Professor Kuka. A round of applause, please. A round of applause. Prof, thank you so much. All right. So this award is also celebrating education and training. And this is in recognition to a dedicated heme oncologist who is dedicated to pediatric education and training in Ghana. I'm happy to announce that he's one of the foundation educators starting Pediatric General Fellowship in Ho Teaching Hospital. And this award is presented to Dr. Koku Hefuame Amega Aho. All right, so we'll call Dr. Lord Mensah to please take this on behalf of Dr. Amega Aho. Dr. Mensah, please do us the honor. A round of applause, please. A round of applause. A round of applause. A round of applause. And there is support. You can see the HOD, Road Teaching Hospital. Aiko to Dr. Amega Aho. Okay, so Dr. Mensah, please, we are not done with you yet. You please stay on. And we are celebrating a man who is the face of pediatric care in Volta region. He has more than 20 years experience in pediatric leadership and governance. He's looking at me surprised, and I don't know why. So this is in recognition for your distinguished leadership in child health in Ghana. We celebrate you, Dr. Mensah. A round of applause. Yes, I think the applause should be louder. Yes, thank you so much. Thank you, Prof. Goka. Congratulations, Dr. Mensah. Thank you. Thank you so much. We'll take our next set of award, and this is celebrating pediatric advocacy. And please, if you permit me, the country director, WHO, could you kindly do us the honors? A round of applause, please. This award is in recognition of your tireless efforts in promoting child health in Ghana. She is known as the face of advocacy in the Eastern region. And if you see some of the beautiful buildings on the hospital premises, it is because of her brilliant advocacy. And you could tell it from her voice as she emceed this morning's proceedings. Ladies and gentlemen, this award is celebrating pediatric advocacy and is presented to Mrs. Francisca Enchi Amamo. A round of applause. Franca, thank you so much. A round of applause, please. A round of applause. The last but not the least, and we are presenting this to Kusia Sewa Jenin. Unfortunately, she's not with us, but this is in recognition of her exceptional work in child health in Ghana. She continuously advocates for children and is known for her work in the Oti region, where she won a grant allowing for early detection of cases of newborn jaundice. Ladies and gentlemen, she has asked that Ms. Delari Sepenu comes to pick this on her behalf. We'll give her a round of applause. We'll give her a round of applause. All right, thank you so much. All right, so thank you all for your audience and award-winning MC. Over to you. Please, a round of applause.
Another big round of applause, please. All too soon, we are coming to the close of the first session. There'll be a second session after you've had your tummies lined with something to keep you going into the second session. We're going to have a few announcements and then right after the announcements, please, we're going to have pictures right here in this order, please. So the dignitaries, invited guests, awardees, please, will have pictures. Then we'll have the LOC join in, and then all of us will be part of the pictures. And then we'll move into the session where we have our snacks, please. Announcements, please.
Thank you, award-winning MC. Please, let's kindly take note of this. One of our very old partners in Pediatric Society of Ghana is the African Health Supplies. And this year, we are looking at how best to support some of our facilities, get very important equipment. We have an arrangement and want to share with you. So please, these are a few of the equipment that we need very much for our newborns and children. And this year, they are ready to halve the price of all these equipments and more. Yes, that's correct. Now, they are also having a survey where you get to choose which equipment is needed for your neonatal care unit and your facility, and they can arrange a payment plan with your facility. We want all Pediatric Society of Ghana members who need this equipment to reach out to them and engage. So there'll be a QR code around, scan it, fill in, and they'll contact you and assist you. The second announcement is from one of our very active members. How many of us pediatricians have had a call in the night from a family member, a church member, a friend, asking for a quick consult? How many were just show by hand? Okay, so one of our colleagues, Dr. Selom, wants to know your thoughts on telemedicine to improve child health care, where when you are providing all these free services, you get where I'm going with this? Yes, so there will be a QR code, just scan and share your thoughts so that we can come together and improve that kind of service and formalize it for our children. So again, there'll be a QR code, advantage points. You can even scan as it's showing. The third announcement, one of the most frustrating experiences for young doctors who are seeking to enter residency is that they don't know how to prepare for the exams. You get calls when they're a few weeks or days away, asking you for some tips. Someone has thoughtfully put together a program, but to make it work and work very well, we want to know your experiences. So this is a survey by one of our colleagues wanting to know your experiences. What would you want in the preparatory material as you are writing up for residency? So again, we'll share the QR code around, scan it, and fill the form. The third announcement, this week is about non-communicable diseases, but we realize that the Galamsey issue, we can't ignore it. So we are partnering with a few companies. One of them is Plastic Punch. Now, when you go down, there's a stand. You can take a free sip of water. Their filtration process is supposed to remove some of these heavy metals. So we are happy to bring them on board as partners of the Pediatric Society of Ghana to advance this our anti-Galamsey efforts. And finally, as announced by my president, these armbands, if you wear them, it's a show of your solidarity. It says that you agree with the society's efforts to stop galamsey. So we are hoping to have a few more of these copies. If you are interested, please, the protocol team would engage you. So thank you. We are going for a snack break, but before that, our MC will have photography and then we'll go for a snack break. Thank you.
Photo, where are you? Okay, we're all yours. I know we have very important dignitaries here and their time is quite precious, so we want to get this over and done with as quickly as possible. So, photographer, are you ready?
We are ready.
Yeah, so how do you want to do it? So the camera is So can we have our dignitaries, invited guests, please, awardees? Just come to the front, please. Perfect. Okay, all right. Okay. So photographer. All right, so we have the LOC, please join. LOC, please join. LOC, please join. Quickly. Do you want chairs in front? National executives, please, and our facilitators, please join. Our facilitators, please join. Dr. Enigal, Prof. Enigal, please join. Yes. All our facilitators, please join. Our facilitators. Hold on. Photographers, are we good? We're good. All right, for the next set, since we're all going to be in, photographers will need chairs because we're going to have all of us on the stage. It won't fit. Yeah, so let's move the chairs. So can we have chairs here, please? While we're working on the chairs, the rest of us, please, Can you please be upstanding? The rest of us, common floor members, if you're a common floor member, just come, please. Yeah. Please, let's all come. Yes, yes, yes. Let's all come. Let's all come. Can you please bring the chairs to the front? Where's my photographer? Who wants it? Where's the photographer? Can you see all of us? All right. At the count of three, let's say PSG. Thank you very much. Thank you very much. Thank you very much. Thank you very much. So can we have, it's time for our snacks. The snacks are at the back, please. The snacks are at the back. Sorry for it. All awardees. Hello, all awardees, please. At the registration desk, please go to the registration desk after your snack. Awardees, partners, and representatives of sister organizations. Awardees, partners, representatives of sister organizations, please. Go to the registration desk, please. We have an honored speaker in our presence. It's my pleasure to introduce a distinguished public health leader whose career reflects dedication, strategic vision, steady service to Ghana's health sector. Dr. Damien Kundire, Eastern Regional Health Director of Health Services, has risen through the ranks of the Ghana Health Service from a medical officer to one of the country's key regional health leaders. He has strong clinical roots, public health expertise, and executive MBA to match. He represents a blend of medical insight and administrative excellence. Kindly join me in welcoming our leader committed to strengthening health systems and improving population health outcome, Dr. Damien Kundire.
Thank you for the introduction. It goes beyond my capability. So I don't know where you got that information from. Anyway, distinguished colleagues, honored guests, ladies and gentlemen, I think we are now in the afternoon. So good afternoon, and it is my pleasure to welcome you to part 2 of the Pediatric Society of Ghana's annual General Conference and Scientific Meeting 2026. After a rich and inspiring opening ceremony, we now turn our attention to the scientific deliberations that form the core of this conference. On behalf of the Ghana Health Service and also the Eastern Regional Health Directorate, I commend the Pediatric Society of Ghana's leadership for its continued dedication to advancing child health and adolescent health through research, advocacy, and professional collaboration. I'm happy to join you and wear my red armband, as you can see. Because the Eastern region is one of the regions that are heavily affected by the menace of Galaxy. When I started my familiarization visits, you go into all the communities and you see evidence of destruction of our environment. Apart from the direct effect, you know, Ghana Health Service is like MTN. Everywhere you go, we have to be there with them. So as the people move into the forest areas to settle, we have to send our staff there. And it's so sad to learn that the staff have to buy water to drink. They have to buy water daily to cook and so on. So we are all in it together, and let's continue to fight. It will not end, but we should not give up the fight. The issues before us today are both timely and critical. From HPV vaccination to the increasing burden of non-communicable disease among children and adolescents, these discussions challenge us not only as clinicians, but as also public health leaders and advocates.
Our role goes beyond treatments. It includes prevention, policy influence, and strengthening health systems to better serve our children. So I'd like to encourage all participants to engage actively, share experiences, and contribute meaningfully to the discussions. Let us ensure that the knowledge that will be shared here will translate into actions and measurable improvements in child health outcomes. So, ladies and gentlemen, with these few remarks, I am pleased to call part 2 of the scientific conference to order. And I wish all of us a fruitful deliberation. And I now invite the professional MCs to take over and introduce the first presenter. Thank you very much. God bless you.
Thank you, Chair. At this point, I want us to give ourselves a round of applause for being here. And also, let's give a round of applause to our online guests, our online participants who have been with us since the beginning of the program. This scientific conference is privileged to have a pediatric nephrologist, who has a passion for child kidney health. He also has a passion for pediatric HIV, a passion for malnutrition. For those of us in pediatrics, we know his dedication to teaching, research, and examination linked across West Africa. He is a professor of pediatrics at KNUST, a consultant at CAF, and has spent several years shaping both patient outcomes and the academic journey of countless trainees. And we do know that he blends this academic rigor with service commitment. He's deeply grounded in faith. We often will see lots of postings from him regarding faith and family life on our pediatric page. He strives to mirror his spiritual values in his professional calling, showing that medicine, mentorship, ministry can sometimes share the same consulting. Kindly help me welcome Professor Samson A.J.
So thank you. Sit down, Patwa. Hello, participants. I'm speaking. Can you come and sit down? Okay. So, Mr. Chair, our own colleague, Regional Director of Health Services, and the PhD President, police, I think we still have the traditional authorities here, media, and everybody gathered here. I have a short assignment just to talk about the thing, leaving no child behind, advancing equitable healthcare for children and adolescents with non-communicable diseases. And I titled my speech a call for action. The media, I hope we are paying attention, but as I try to grant interviews, it is important for you to know that children also suffer from non-communicable diseases. For us as doctors, I'm sure it is not so surprising to know that children also suffer from non-communicable disease. But I'm sure for non-medics, when we tell them, we come surprised. Probably for diseases like second sentence, they have heard because a lot of them are children they know. But if you tell them that children suffer from non-communicable diseases like kidney disease, like diabetes, cancer, the rest, then they become such. And most of the speeches that went on in the morning, they mention asthma, mention sickle cell, mention cancer. But for all the speeches that it said, I never heard anyone talk about kidney disease, also as non-communicable disease. I don't know whether the healthcare workers we are also ignorant of this, that children also suffer from kidney disease. You come to my kidney disease clinic, I have over 500 children. So I can tell you. It's a big listen. And we tell them that children are taking antihypertensive since they are, the people don't believe it. So it is real, actually. Non-communicable diseases in children and adolescents. They are real. Yet there's little emphasis. National campaigns and plannings, I think there's little emphasis. And if we look at outside the teaching hospitals, I wonder how many district hospitals actually have services that are tailored towards non-communicable diseases of children. So remember, I'm talking about call for action. One of the things we need to actually look at is to get all our district hospitals and sub-districts to be aware and the authorities to design programs to make sure that children are not left behind, and that we also group them in. So, how many people outside the teaching hospitals probably consider checking blood sugar for children? Without the outstanding chief exam. Thank you, Nana. So I can continue my speech. So I'm saying outside the teaching hospitals, where we know of some of these non-communicable diseases in children, even all the speakers have said that they not even mention kidney disease and the rest. How do you will anybody even check a child's blood sugar? And so one of our lead epidemiologists in Ghana, Dr. Abia, have been fighting that not even doctors they can't diagnose pediatric diabetes. Doctors. That's a lot of children with DK who even come abdominal pain, then they are referred to surgeons, and it's always fighting. We don't check blood sugar in children. Probably we only call to action to check blood sugar when the child is convulsing or conscious. And how many health workers know that it is mandatory for any child with 3 years and above to have this or that BP checked as part of standard of care? No adult can go to a hospital, doctor sees you, I'm taking your BP, and boom. But actually, for children also, any child in 3 years and above have BP check. Do we see space? My hospitals, are they there? Outside teaching hospitals. So if you are calling for action, these are the things policymakers to take note of this. So that things like that, glucometers should not only be reserved for adults, children must also benefit from life capture. And pediatric space are hospital purchase when we are doing equipment purchase. And not only given to teaching hospitals, to the peripheries. Because every child, 3 years and older, needs the blood pressure check. Otherwise, these situations will leave a lot of children behind. Diabetes will not be diagnosed. Childhood hypertension, which is variable from the kidney, will not be diagnosed. When we talk about equity, we require intentional design of policies and services to address this about increasing burden. And so, national policy and strategic plans must make sure that pediatrics, adolescents are also included in the NCTs program that they have. Another area that we also leave behind often is adolescents. You know the struggle we go through if a child is more than 13 years and is not yet 18. Don't know where he belongs. And so we come to the pediatric world, we say, we see up to 12, so we see up to 12, we see up to 13. We say it depends on your size. And then the person is 15 years, the adults want to say, no, it's a pediatrics. Because adults will start from 18. So we see that particularly pick up adolescents. So we struggle really to place these people when they are sick. So in that situation, there's not a easy that we actually leave them behind. I know that traditionally, pediatric diseases have focused on infectious disease or communicable disease. And so when immunization programs were designed, the EPI, they've really achieved much as far as infectious diseases are concerned in children. And they've reduced mortality and morbidity of infectious disease significantly. I even know that even for malaria that strikes, they get national vaccination. I know pilots are going on certain parts. So kudos to EPI, what they've done. But I think increasing the whole world, and Ghana is not left behind it. Non-communicable disease children is increasing. So children are having double burden now. Infectious disease is still fast among the children, and non-communicable disease raising its level. It's contributing to significant morbidity and mortality, children and adolescents. And so, Mr. Chairman, audience said that the pediatric non-communicable diseases, they are not rare. They are not rare as we would think. They are not rare. And they are not future progress. They are with us now. They are with us. And therefore, whatever we plan, we need to make sure that when we are planning non-communicable disease, to have children, mind, program, and cover them. When we started running pediatric subspecialty clinics, sometimes you wonder, all these children with non-communicable disease, where were they? We wonder, where were they? Because once we started running subspecialty clinics, a large number of cases in our clinics. So where were they? They've heard that we ran diabetic clinic, and we ran kids clinic. So they are all coming. So it means they were there, hidden out there in the community. Nobody knew. And so now we have large number of children. The renal clinic, I've said that in my own clinic, have more than 500 children. Even gastrointestinal clinics, we have a lot of non-infectious chronic liver diseases, nutritional diseases, both undernutrition, overnutrition, cancers. Thank God that is receiving attention. Pediatric cancers, I think a lot of our places going short attention. But even in hematological conditions, it is not just sickle cell. Hemophilia is a very big problem. And sometimes I see some of the children and all the arthropathies here. It is sad. We know of neurological cases, cerebral palsy, epilepsy, autism spectrum disorders, asthma has been mentioned before, cardiac disease, endocrine, mental health has been mentioned. Of course, we must not forget about even dermatological conditions of non-infectious origin. The SMS and the rest are all there. Now, the challenge with non-communicable disease children and adolescents with that. They have a lot of interrelated medical, psychosocial, educational, and systemic challenges. Remember, if a child has got a long chronic disease, it means it's a lifelong illness, most of it. So it requires continuous care. There are frequent hospital visits, frequent medication purchase, a lot of procedures to undergo, they suffer pain, it delays their growth and development, and even risk of complications and early mortality. They have a lot of psychological and emotional challenges. You know, adolescents, sometimes they can't take it in. And instead of coming to school, always they're coming to the hospital. They fight against things. Social challenges like stigma, discrimination are there. And educational challenges, school absenteeism due to illnesses and clinic visits. They may have learning difficulties and lack of school support. Even though we are trying to do something about school health program, I think we need to expand this. But the economic challenge, family challenge are huge. The call for action must actually look at that. There's a high cost of long-term treatment and care. Once know the little money you get every month coming to a clinic. That's a lot of money. And the financial strain on families sometimes lead to poverty. Can children diagnosed with non-communicable diseases, which are chronic diseases, also get some social support? I'll put up here. You know, they have a program in Ghana called LEAP, which is a livelihood empowerment against poverty that they give to families. So, can we also get some social protection for children who are identified to have these chronic diseases? Something we need to think about. Otherwise, families are rendered poor because they are caring for children with non-communicable diseases. Now, we emphasize that the cost indications in managing these non-communicable diseases are not just limited to prescription for medicines which never end, and the laboratory investigations and the rest, but also lots of man hours for the parents. You have to leave their job and take these children to hospital. And remember, most of these parents are in the informal sector. You and me, even if you don't go to work for 2 weeks, our salary will come to drop. But for this, in the informal sector, every lost hour is important because they need to actually be in the market, sell their things every day. Having counted that, and so I think our advocacy must actually do that. Governments must look at it again. Now, I conclude, I'm going to conclude. And I think our call will be probably to actually advocate for some social support for children who are identified to have this non-communicable disease. In fact, transport even to and from hospital, sometimes people overlook that. You think that whatever they can say, they are providing insurance for that. What about transport? Transportation come and go. And when they come, they must eat. But when they come to a clinic, you don't feed them. You feed them. So they have to buy food to eat. These costs are being considered. That's why I'm saying that we will need really to advocate probably for some family for non-communicable disease in children. Cost of certain medicines are so expensive. Insulin is expensive. I remember when I started a different clinic, and they didn't have free insulin. Now, some partners are giving free insulin to children in Ghana partners, not Ghana government. And they didn't have that. There was a time, all the cohort of children with diabetes, they were telling me that all the children are connected. All that because before this free insulin came, because they can't buy the insulin. Where do they think these stories? Can we continue like that? Thank God that we have these partners who are now providing free insurance. But I think as a government, as a nation, we need to look at the model of funding for these children with non-communicable diseases. So like I've said, can we get something similar to LEAP? If you are giving LEAP to the aged, can we also look at children with these non-communicable diseases so that they can be supported? Adolescent transition. I'll talk about the fact that children who are 13 years, 17, don't know where to place them. And sometimes we throw them back and forth. We have tried in my hospital, for example, to try and do transitional clinics. But it's fraught with a lot of challenges. As expected, usually the pediatricians are willing to come. We are having a joint clinic for adult police. So we will be there. But adults will not come. They won't come. Because of that, we still have children who are in the universities. They are 23, they are 7 pediatric. I think as a nation, we need to take this one seriously. Ghana Health Service Director, that we need to have proper transitions. When children are 13, they are 12, can have a joint clinic. That's what that use this joint clinic. And the adults show commitment. They have one time at home with adults. I don't know what is happening, whether they can't sit for long or whatever. And so, because I was given a short time, yes, the call for action. And I take note of that, Madam President and the Director. I think that what we need to recommend as a society is that, Ghana Health Service have got a non-communicable disease wing. I know they have that. And I doubt whether the program that they got, the policies, they have pediatric non-communicable diseases. If they are not, I think my first call is that you should integrate pediatric non-communicable disease in the national health plan. You must tell them that they must include pediatric non-communicable diseases. Whatever they are doing training, to buy equipment, talk about pediatric space and the rest. And equipment so that they consider and then they will teach their primary health care teams. That's the second call. Strengthen the health workforce. We must train primary health care teams on pediatric chronic care so that pediatric casts are in part of our equipment packages. If it is for me, I'm finished. So that pediatric casts are in part of our equipment packages. And checking blood glucose of children should necessarily be included in the care that you do at the different sub-districts. We must also incentivize pediatric society training. This morning we heard that two of our oncologists in Northern Ghana is helping a lot too. We need to incentivize pediatric society training and retention, especially in underserved regions. And for this, I think Ghana College is doing something great, but this decentralized training of fellows that we are doing, and I think government needs to support Ghana College. I know that they are facing challenges, but of course, the good will is the Ghana Health Service support. Recently, I went to do accreditation work, and Ghana Health Service was part of a team that went there. It's a good step. Need to strengthen that. We must expand the health financing and the insurance. We will say that any child under 18 years don't need to pay a premium. Insurance covers. They are being taught. They are taught. The practical difficult. Sometimes they'll tell you the inclusion of that child depends on the parents. Even though strictly the policy like this says so. But a lot of these children haven't got insurance. You say that under 18 is free, but they haven't got insurance. If you ask them to go and even do the insurance, going to the place where they do it, even the picture to go and take whatever, there are challenges. So we haven't got these children covered. Though it's a system of policy. For me, I think that governments must take the mobile They must register necessary every child in school. Go there and register them. Take your camera there, take it. Take their pictures. Instead of telling them to go to the insurance center to go to work their child at 18. It's not working. And so we see 6 children, I see 6 months old, I see 1 year old. The mother has nothing. And then having no insurance. Even though the policy is saying any child under 18 should be covered by insurance. We are just talking. And so for me, yes, let us say government should go to every school. Private, those who are going to be left behind, maybe those who are not in school. Even those who are those in the streets, you can rope them. Just can't get the camp. Let's give you insurance. But all those in schools, they must register them for free. Because we say it's free for any child under 18. But in practice, it's not happening. Must do that. And I know what National Health Insurance is doing. They're doing well. They cover hydroxyurea for seconds, cancers, they're covering some factor concentrate, hemophilia, because I see them all the time. It's also given by donors, just like diabetes, the insulin. Government must look at that. Now we have Mahama Care, isn't it? Which is trying to. So we need to advocate for some of these things. Because if these donors, probably we thank God that the donors are not from America, but we know what Trump did. Then we also. And so, as a nation, you need to consider getting some of these covered. Medicines that we use for these non-communicable diseases, like factor concentrate, insulins, cancer is already covered somehow. And dialysis, we thank God that the government is now covering some aspect of the dialysis, but honestly, the amount they are paying is not the full cost. They pay about 480 something cedis, but the actual cost is about 800 cedis per session. And government is only paying for 2 sessions a week. Transport to come for them. No, where the dialysis are far away. They have to travel far away to come. Money for transport itself is a challenge. That's why I'm saying that if there's a new, let's find another way you can for children money is find another way. Beautiful like you, and let's advocate. But my can something. So that we give some funds to care for some of these children. I know that organ transplant is not yet a reality in Ghana, so expensive we can't do it. But I think we need to consider we have got so many people who need transplant. And we should cover this. In Sudan, Sudan is fighting, they are fighting in war. It is free for them. Sudan, everybody has kidney disease, get dialysis for free, they get transplant for free, they don't pay anything. Not from insurance, it's from budgets. Budgetary application. Sudan. And so let's be talking, Madam President and Mr. Chair, that we need to do more. We know what we are doing, but we need to expand it. But I'll end by saying that probably to consider some cash transfer along what we do for the new program. So that when children have got chronic disease, diabetes, kidney disease, they are attending clinic, asthma, blah, blah, they can identify it. And then someone can be sent to the parents, cater for all the other non-insurance costs, suited with their care, transport, means, and all that are coming. In that way, I can tell you that we will not leave any child behind. As it is now, a lot of people actually they are buried underground, don't finish here. They are left behind a long time ago. Thank you very much. By the way, I support the LMC. I want a head man also.
All who know Prophet, you know that he has never changed, right? Anyway, please let me use this opportunity to acknowledge these important personalities in our midst. We have Prof. Vida, a rep from HEFRA. Prof. Vida, you're welcome. And Dr. Chadi Dawson, President of the Medical Women Association of Ghana. You're welcome too. Please, can we now take a word from our representative of the Assembly.
Thank you, first of all. And I would like to say a very big thank you to Professor Benji, who just doing a lecture. For my understanding, I think he's really done his due diligence properly, and he really knows and has facts based on what he's talking about. So I would put an edge with all of us in here and all the people that are involved that can make all his concerns be addressed for the better, should please try and let's all help out. I'm really happy for the events today, and it's kind of like enlightened me a bit much more about things that I thought I already knew. And I appreciate you for that. On this note, I'd like to stand on behalf of the Assembly Equity Watson III, the paramountcy and overlord of New Drabin traditional area, whom I'm representing today, and say a big thank you all for having us. Thank you.
We are so grateful and the Japan, the Abuafohele of the New Japan traditional area. Thank you so much. Thank you so much. Shall we take up? The next presenter in this session is an astute public health and C-SHIP specialist with a decade of leadership in the Ghana Health Service, currently serving as the program manager for the expanded program on immunization. A KNUST alumni with a Master's in Health Policy Planning and Financing from LSHTM/LSE, and a fellow of the YALI and IPPHL programs. She is known for her principled, goal-oriented leadership in vaccine delivery and health systems strengthening. Today, she presents on building a future free from cervical cancer, national strategies and global commitments on HPV vaccination. Ladies and gentlemen, Please welcome a leader dedicated to protecting the next generation through vaccines and prevention, Dr. Selom Kuchwati.
Hello, good afternoon. I'm very happy to be here to see some of my lecturers and people who were residents the time I was a medical student so many years ago in KNUSC. I'm also happy to say that Dr. Entry was talking about equity. HPP is one of the interventions that really promotes equity. Before this vaccine came into Ghana under the routine immunization, it was only those who could afford that would get it. Now, whether you can afford or you can't afford, the vaccine is available. Once you are eligible, we are ready to provide the vaccine to you free of charge. So I'm here just to give you a brief presentation on HPV vaccination, what our current status is and what the future perspectives are. So these are basically what I'm going to talk about. I'm going to give a brief background of our program. I'm going to talk about its vaccination. I'm going to tell you what happened last year when we did the campaign. Before we did the campaign, ESC gave us a big platform. We met health workers, we met people. We spoke about what we intended to do. So traditionally, I should come back and report to you what we went to do after the campaign. Then I'm going to tell you a bit about what is happening or what we expect to be happening with vaccination, and then we'll conclude. So this is our country, Ghana. I'm still using 2025 population because we are looking at data from 2025. But we know what our country is like. As of last year, we had about 1.3 million surviving infants. And we use surviving infants for our vaccination coverages to calculate the doses and what the coverages are going to be. So I'm going to talk about the EPI program. So in 1974, the WHO gave a resolution for immunization. In 1978, Ghana decided to start a program. But that doesn't mean that immunization started in 1978. There are people here, I'm sure, who received smallpox, other vaccinations before then. But the formal EPI started in 1978. We started with vaccine vaccines, DPT, measles, and other things, and gradually we scaled up. And by 2025, when the year was ending, we're giving 12 vaccines and vaccinating against 15 vaccine preventable diseases. And we use a variety of strategies like pediatricians. I know you have a lot of detail about what we are doing. And we offer our services at a decentralized level. So everywhere you are in this country, every nook and cranny, we have our staff who are providing vaccination services free of charge. So what's our goal? Now we are looking at the life course approach. I know this is a pediatric audience, but EPI now has gone beyond just protection of women and children, like as what we used to do traditionally. We are looking at the whole life course approach, and the COVID vaccination was a classic example of being able to use the life course approach to all our work. And I know that in the future, there are other factors that are coming up. Last year, we gave out Mpox vaccines. That was also given to adults and males as well. So our traditional focus from just children and pregnant women is now expanded. So I think with the pediatric group now, actually we're not just covering you anymore. Our focus is quite bigger than just the children. So these are diseases and the vaccines we give. I'm not going to dwell here. And this is our chronology of what we started with. As I said, 78 is when the program started. That was when vaccination started. And now, last year, we produced HPV, which is our newest baby. So this is what our routine immunization coverages are like. This is what we call the WINIC, the WHO UNICEF estimates of vaccination. And this one goes beyond just using our administrative coverages. So they look at a variety of data, survey data, they do test reviews, etc. And for Ghana, consistently, we've been doing very well. The vaccine, I would say the international threshold that is used for assess our program is about 90% coverage, with the exception of MCV2, which is measles containing vaccine 2. And in Ghana, we give measles rubella, which is given at 18 months. And we all know what happens by 18 months. Half of the people here, children will be in creche. And when you go to creche, they will say, we want parental consent to take vaccines. So with the exception of the 18-month vaccine, all the rest are around 90 and above. This our program is very highly performing. This is what the demographic and health survey also gave us. The last survey was in 2022, and we had a list of vaccines that give a child what we call the fully vaccinated status. That is BCG. We give 3 doses of the polio containing vaccine, which in Ghana is the OPV. We give DPT containing Ghana, we do pentavalent vaccine, and a single dose of the measles containing vaccine. So the 9 months measles. In 2022, they found that 73% of the children sampled during the health survey had been fully vaccinated. And they found that about 2% of them haven't had.
Sorry for interrupting this. This is very important. If you spent your night here at Eastern Premier and you haven't checked out, please check out in the next 5 minutes, so you'll be paying for tonight as well. So please, if you spend the night here and you are yet to check out, please quickly go and check out so that you don't pay extra. Sorry for the interruption. Thank you.
Thank you very much. As I was saying, just about 2% of the children that they found had not received any vaccines at all. Can I continue? Okay. So I'm going to talk about HPV. You see a nice student in the corner, typical adolescent, something is happening and there's peer pressure. Somebody is taking vaccine, somebody who has not received the vaccine is already feeling pain in their shoulder. So in 2025, Ghana embarked on an ambitious program, and we wanted to introduce the HPV vaccine to children aged 9 to 14, in fact, girls aged 9 to 14. I have to emphasize girls because somebody really even today was expanding boys. And we didn't just do this as a vaccination, typical vaccination, as I talked about. We're really finding adolescent health equity and also trying to eliminate cervical cancer in one generation. WHO is aiming for elimination of cervical cancer by 2030. And they have 3 interventions they are doing. They are doing a combination of 3 things. We are looking at vaccinating girls, eligible girls, about 90% of them, being able to do cervical cancer screening, at least 2 of them, 35 and 45, and then also being able to treat everybody, about 90% of those who are having cervical cancer by 2030. For us in Ghana, we are starting off, or we are looking at vaccination, and that is more or less lower hanging fruits than the other 2 interventions, because they rely on people having to go forward for testing. And also, they also rely on also having staff and equipment. I don't know how many oncologists there are, gynae oncologists in the country who are going to treat 90% of cervical cancer cases. I'm not sure we have the facilities to do that. But the vaccination is a bit easier because once we the girls know that at least we are protecting them going forward. I saw a study yesterday about some people modeled vaccination and realized that once you do this vaccine, I think you need just 2 screening for the rest of your life. I saw it was shared yesterday, I think, from Medical Women's Group or something. That's quite a good thing for us. It actually translates into reality. So what did we do? Then I took a multi-age cohort campaign, which what we call a multi-age cohort is that multiple ages. Typically, we just do 1 group, but this time we did 9 to 14 years, and across all the regions. And we targeted about 2.2 and reaching about 2.2 million girls. And we did 2 strategies. We looked at the school-based one, and then we looked at the community or out-of-school girls. And we did a combination of community outreach, fixed posts, and then we went around trying to make sure that we don't leave any girl behind. What did we find? On the 8th, we launched our vaccine. Our minister is in the corner with the ceremonial first girl to take the vaccine. We had a group of stakeholders here. Hilda was supposed to be here. I don't know if she was here or not. We were there for the launch in Accra. Then we did a campaign. We met our girls in school. We met them out of school. This is the corner. In the corner there is Salaga Market. Our staff went to Salaga Market, trying to identify the girls who were not in school and had not received the vaccine. Went to the code box and able to get some girls and vaccinated. Went to Makaranta, went to churches as well. So at the end of the campaign, we were able to achieve about 84.5%. That's a modest performance, 84.5%. We wanted to do about 100%, unfortunately, we went to 84.5%. And the main reason this happening, I think I'll talk about a bit more as we move along. And if you realize, Greater Accra, curiously, where our bourgeois, our educated people are, had the lowest percentage. It's about 65.7. And if you drill down to Greater Accra, some districts with performance of less than 40%. And you ask yourself that this is supposed to be Accra. And some of these districts are urban. It's not urban, peri-urban, urban, rural. I mean, urban. For instance, please, is there any rural place at Newtown? Mango, we also know Accra. But these people are in about 40%. And you ask yourself, how can this happen? Because these are the people who are exposed to the radio, they're exposed to TV, we've gone to the communities. What's actually happened? This is a nice graph I'm showing. Before the campaign, this graph, Ghana was not passed. But luckily for us now, you can see we are nice and clean. We have joined the League of Countries that are looking for it to protect our girls from cervical cancer. Now when they talk about people who have vaccines, we take their song. There's something I'm very proud about because before the campaign, we're not on it at all. And this is something I want to dwell a little bit on, which is the AEFIs, or Adverse Events Following Immunization. This was something that ahead of the campaign, we had so much noise about. Immediately you talk about it, and somebody will say, if I take the vaccine, what will happen to me? What will happen to me? Am I sure this is not going to kill my daughter? Won't it kill my son? When we're done with it, we found just 432 out of over 1.8 million people. Please, is this significant? Pediatricians, is this 432 over 1.8 million? Is this significant? It's not. It's not. But of course, we have to tell the people because we don't want somebody to say it and get headache when you say we don't leave it out. As part of this communication, all this adverse events that could happen needs to be told them. So you can the rate of adverse events, this region had a high for 232.2, and the lowest was OT region. And you can see that it wasn't a lot at all. What we tended to have were fever and headache. Those were the major things that were reported as adverse events for the vaccination. We have two, in quotes, serious adverse events. And I'm saying in quotes because once somebody comes and says they have an adverse event and they require admission, we report it as a serious adverse event. However, when causality analysis is done, then we will take it off. And for those two, one of them had appendicitis, second person had tonsillitis. And because they said they were sick enough to require admission, we put it there as a serious adverse event. But in reality, we know that once causality is done with FDA, it will no longer be a serious adverse event. So I've just mentioned it as a matter of note. Number one challenge, miscommunication, misinformation and misconception. And this one, I remember day 3 of the campaign, a certain somebody who shall remain unnamed went on TV and radio. I was around 6 a.m. I was getting ready to leave the house. And people told me, check your phone, check Facebook. Somebody went on a tirade for about 15 to 20 minutes, talking against the vaccine. And the effect was swift. People called me later to say that any schools and parents who had agreed for the vaccine to be given by then all withdrew their consent. We know vaccination in Ghana does not require consent. However, because this was being done mainly in schools decided to introduce consent. And that came with the issue because once there's somebody whose name I'll not mention goes on radio and tells people that the vaccine was not tested, some people are not giving it. Why is it that comes to Africans, they want to kill us? That's the end. And the parents will say don't give the vaccine, the schools will shut their doors to the staff. Then also, we did have some inadequate funding. As against the campaign, we had targeted some funding in foreign currency. By the time the foreign currency arrived in the country, the city had developed muscles. So So what we were supposed to have received based on our proposal, the funding reduced significantly. We also had a lot of supply of vaccination cards. You know that in some districts and some regions, this was a challenge because some people wanted to make sure they had the cards before they gave the vaccines. Then in hard to reach areas, you had limited cold chain capacity. This vaccine is given one in a box. So it's not like the one that has, it's not a multi-dose vial. So if you are going to immunize 100 children, you have to carry 100 pieces of the vaccine. So if you don't have enough cold chain capacity, that becomes a challenge for us. And then health worker fatigue. You can imagine, we are doing this campaign, that campaign, in fact, that same week, Western Unity was doing MPOS phase one of the campaign. So they are running both things simultaneously. And all this led to the reduction in the coverage. So what were our number one circulating myths? And people say HPV will cause infertility in girls. I don't know where the research came from, but unfortunately, this was quite something that was going around. And we think that it's something that as people who have a lot of knowledge, we have any time we hear this, we address it holistically. Others said it was an experimental vaccine. This vaccine has been in use for decades. There's nothing new about Agsm 4. Nothing new. Yes, they said it's an experiment. Some people said it will promote early initiation of sexual activity and promiscuity. And those who were at the GMA AGC, when I did the presentation, that was a comment from colleague doctors, and they felt that this vaccine will promote promiscuity. I'm not exactly sure how HPV causes promiscuity, because if somebody has sex, it's not just HPV they could get. They could get pregnant, they could get HIV, they could get other STIs. So it's going to take the HPV vaccine doesn't mean you are licensing you to go and have sex, but this is a perception that was out there. They said it was being brought by Bill Gates as a population control agenda, the usual things. The government had been paying billions of cedis or dollars to introduce the vaccine. And for this, I was very concerned because it appeared that I was the face of the vaccine, but the dollars never entered my pockets. So if any of you know where the dollars are, let me go and collect my share because it looks like I've been short still. And then they said some people too said that because the vaccine was developed out of Africa, it was toxic to Africans. So, what are our next steps? Routinization. And today somebody was asking if the vaccines are available. They are available. The demand, however, is low. It's very, very low. We are looking at how we can improve our school health. Today, Dr. Prophetic spoke about school health and using it for things. But what is happening? Are people doing the school health areas as they are supposed to? Because it feels to me like they prioritize children, the under fives, go and do the screening, check the ears, eyes, and the send. But the adolescent part not doing too well. And that is the part where you'll be able to pick the eligible girls. We have our vaccines available in the facility. As I said, the demand is not very good. We are looking at using some targeted vaccination sessions through our outreaches. We've targeted some districts to intervene in. We have a support from JSI. In Greater Accra, they selected 3 districts they want to support. We want to bring up their coverage. And then we want to do periodic intensification for immunization and also improve the documentation. Because as we said, the cards are not being put at the beginning. This caused some delays with the vaccination. So health workers, this one, the imperative, this one is for us. What am I charging health workers to do today? I want us to look at dispelling myths and also addressing concerns about side effects. The data I brought you is what we got at the national level. And with this campaign, we're having very actively following up for any reported side effects, adverse events, and this. I've presented what we have and what we have given the FDA. The FDA will report to the international regulatory bodies on vaccination of HPV. You can see the side effect profile is very good. It compares favorably with our child immunization. So there's no fear about having adverse events for which we say parents should take their children. And also the myths they are going on, they are myths. Unfortunately, we have colleague doctors and colleague nurses who are actively propagating these myths. And it's difficult to be able to reach them individually. And the program, we are trying, but we don't get at our level, we are doing national level. You are the ones who interface with the clients, interface with the parents on one-on-one. When they come to you, please give them correct information. Then I want you to reinforce that the vaccine is part of our routine immunization. So this vaccine is not a campaign that we came to do as a one-off and we went away. The vaccine is available. We have adequate stocks in the country. No place where vaccination is offered should tell you they don't have vaccine. If they tell you, please come and tell me. Because I have more than enough HPV vaccine in this country for us not to have any stockouts. And then we also tell them that the vaccine is not new. It's not an experiment. We did some trials with this, a pilot in 2012 to 2015, with the same vaccine. There's no new formula, it's the same one. And that one, the girls who are there, they are grown, some of them have had children. So the vaccine is not an experiment. Then finally, I want us to provide clear, emphatic, accurate counseling. Where we are not sure or we don't have adequate information, please let's reach out to get the information. Because there's nothing worse than giving half information to parents and they go to the internet and they find all the anti-vaxxer content. And then now it's like the doctor, when I came to the doctor or the nurse, the person couldn't address my concern. The person doesn't even know much about it. So why should I, a non-health person, be able to do this? So in conclusion, it's a lot of text. What I want all of us to go away with is that we have done, EPI has done so much with normal routine immunization. We've worked with polio, we've eliminated prenatal tetanus in Ghana. Measles was doing well until some time ago, but we are trying to catch up with the measles again. And we are trying. It's hard, but we are trying. We have done so much, and the HPV campaign is not just campaign, it's a public health milestone. And it's supposed to help us to address equity challenges within our country. And then finally, I want us to work together because EPA as a program cannot do everything. We have to work, all of us, nurses, doctors, media men, lab, everybody should work together, pharmacists, to ensure that these vaccines are available, the right information is given. So the case we have made, we'll consolidate them and we'll also go further. So this is my EPN. Everywhere you pass, we are there. We are in water, we are air, we are in the land. Every corner of Ghana you go, I'm sure you've seen our Peter's code boxes. You see us our gray or blue code boxes, and we are there to provide vaccinations for you. Thank you very much.
Thank you so much, Dr. Salom, for the wonderful presentation. Mr. Chairman, please permit me to call on the President of the Pediatric Society of Ghana, Dr. Hilda Boyd, to give us a presentation on the key role and impact of pediatricians in the acceleration of VCR, a call to action. Please, with a round of applause.
Thank you very much. Thank you very much. After Dr. Joanti's presentation, I don't have so many things to say. She's captured a lot of it, but I'll go through a few slides. Next slide. So for us as pediatricians, we are the first point of call often for the parents when they have concerns or are not sure about vaccination for their children. And so we need to be able to deliver a strong and trusted recommendation to them. When they come with their anxieties, we are the ones who have to give them evidence-based explanations and solutions. If they have any concerns about it at all, any adverse reaction, whatever it is, we are the ones to give them the recommendation and help them. We need to also advocate and try so that there's a reduction in the missed opportunities for vaccination. For HPV vaccination, we all know that the target is for now is the 9 to 14-year-olds. And these are students, these are children, adolescents who are likely to be in school. So where possible, work with the managers of the hospital or the facility so that the services can be available for them at a time when
they can easily come in and take their vaccines and go back to school or go back to learning. So this also ties in directly, try to improve access and convenience within the services. And there's a thing about adolescents, they don't want to mix with babies and infants when they come for care. So we need to try and work with the public health units within our facilities so that the services are friendly for them, they are tailored towards their needs, and they are comfortable when they get there. We also need to strengthen reminder and recall systems, okay? So when they have come or we know that they are supposed to come, are we going to give them the date? So are we going to send them reminders, messages? I know we don't usually do it for the apart from when they come to the clinic, but we could look at it. Text messages, WhatsApp messages, reminders or calls from the nurses could do. Next slide. Then data. Data is important. We need to be able to look at the data, work with the data, look at what is going on within your facility. If you are interested in other facilities to see, are there barriers to them having the vaccination? So once we have the data, then it's easy to measure if there's a problem, the size of the problem, and look at what possible solutions that there can be. Vaccine hesitancy is a big deal. Previously, we did not used to have many problems with it, but now there are so many anti-vaxxers everywhere, and they are also very loud, and this can cause people to become hesitant when they have to go and take the vaccine. So as part of our education and the OPDs, our communication needs to address this, and we encourage them. Sometimes you may have a mother at the OPD who has come with a child who's maybe 4 years or 3 years or 2 years, may not be eligible for, I mean, it's not eligible for the HPV vaccination, but they may have a niece at home who is eligible, they have an older child at home who is eligible. So that constant education and reminders serve to help to reduce the vaccine hesitancy. We also need to be able to manage the safety concerns and adverse events following immunization. I think she spoke about it very well, so I will not go much into it, but then reporting where appropriate, to let them know what to expect and to report if they have any reactions or any symptoms that they are worried about, they need to come back to hospital. Zero dose. We want, so if we say we want 9 to 14 years, children from 9 to 14 years to be covered, these are the age ranges that we are targeting, and we need to try so that we get them to come and have the vaccination within the time. I remember some years ago when I inquired about the cost of the HPV vaccine, the rate I had was around 2,000 cedis, 2,005 cedis or so. Now we have this vaccine available and it's totally free. One of the key messages is that the vaccine is efficient or effective, it is available, it is affordable because you don't have to buy it, and then it's also free. So we do not have any excuses or reasons for not getting the children within these age ranges vaccinated. Policy advocacy and workforce development. When we have our meetings, we discuss some of these things. If there are any concerns, we address them and we forward them to the relevant stakeholders when we have the committee meetings on immunization and all that. So far, we haven't had any serious concern. The only concern was that one of the key concerns was lining up all these children to receive, all these adolescents to have the vaccination at the same time. So they look on while the other children are being vaccinated, and that makes them not want to have vaccination or makes them irritable, anxious, and all. So we need to try and look at that. But policy advocacy and then empowering our healthcare professionals. We've spoken a lot, Dr. Puchwati said a lot, and I've also tried to add a little bit more. Ultimately, the HPV vaccination is here now. And through the Ministry of Government, Ghana Health Service, we know that it's available. it is up to us as pediatricians, as child health advocates, pediatric nurses, public health nurses, and all these key professionals, even our teachers, to talk to the adolescents about it, to talk to their parents about it as well, and encourage them to get vaccinated. Cervical cancer kills, we know, and HPV is not just a cause of cervical cancer. Anal cancers, oropharyngeal cancers are all cancers that people can get from HPV infections. And so if you have one mother, 35 years, 40 years, who dies of cervical cancer, then it's one cancer too many, because this person could be the one who is caring for the family, the breadwinner, the one the children are depending on for that emotional support, getting them ready for school, cooking their meals and all that. So HPV vaccination is important. It's now available. We all need to try and ensure that we do our bits in empowering healthcare professionals, empowering the patients and the adolescents to get these vaccines, so that we do not have a time where we will continue to have cervical cancers or these other cancers related to HPV, which is preventable, which could have been preventable by the vaccines. Thank you very much.
Please, can we have all the presenters on stage for our question and answer time? So if you have any question, Dr. Kuchwati is going to help us with this. Please let's have Miss Dr. D. Kofi also joining them. Yes. Thank you.
So, in person, do we have any questions for the speakers?
Yes, Dr. Chimaje here, Johnson and Chimaje. So thank you so much. I really enjoyed that. I would like to hear a little bit more about decisions about vaccinating my children, just recognizing the role of men, men in transmitting HPV. Although they're not obviously as high risk of cancer, they really are part of the problem.
So thank you very much for all the enlightening presentations. This is the follow-up to the question that was given. So I was surprised to hear that we haven't started rolling the HPV vaccine out to males. Because I was in my office one day, I had a call from my mom that my nephew school is vaccinating males. So should he go ahead and get it? So I actually thought that we started rolling it out to males.
Can we have one more question? And then
Thank you very much. I would like to find out how are you going to handle the misinformation and the information about the myth. Sorry, at that period, how are you able to handle it? Well, update on that. Thank you.
Please go ahead.
Very voice. So I'm surprised people are giving voice because the guidance clearly said girls 9 to 14 years. So I'm very surprised that somebody that's I'm sure they're going to report. I don't know how they report it because they have registers for the children. They're supposed to put their names in the rest. So thank you very much. We will investigate that. Secondly, about the voice. Currently, our program is targeted cervical cancer. HPV does cause other things. It causes dental ones, causes head and neck cancers, anal cancers, and penile cancers. But what the research has found is that able to vaccinate about 70% at least of the girls, the boys have a secondary protection, such that the who are susceptible unless the circulatory HPV virus is so as much as we're not targeting them directly now, if this program goes on as we plan it, the boys will get protection. And we in the greater plan, we hope that we'll be able to expand to boys. But the challenge that the boys we targeted at cervical cancer, it was very difficult to get that in family towards the boys. And then the question about the disinformation. But what happened was quite dynamic. Some regions, when they saw who created voice notes and sending these out, they also created voice notes, the banking, the myths that were circulated. We also had quite a lot of media engagement at that time. So immediately we hear of a particular circulated myth of misconception. All those, we had a platform for communication. She was part of the platform. So when we hear something, we put it there, such that any of us who goes out and has the chance to meet people, to address that particular misconception of which we have had, in addition to the ones we already had kind of in our pocket that we're talking about. So there were lots of strategies that we did. We had posters and things, we had a fact sheet. People would ask you to send them the fact sheet. So the fact sheet also answered some of these things. We kind of preempted some of the myths. So we had a fact sheet, we sent the fact sheet to you. We sent you links. We had support supporting us with a scientific brief. So even the colleagues who were not sure of what we had, send them the scientific brief with the references, asking that if you are not sure, you can always verify the references for yourself. A lot of how to address the misinformation in the campaign. I think a few of the common things that kept coming up during interviews was whether it's the children will be able to have children, the adolescents will be able to have children when they grow, like it's a family planning method. And what we kept telling them was that previously, when it was rolled about 10 years ago, the adolescents who had the vaccine are alive, they are well, and some have had children, they have their families, so that's not something that we are afraid of. Another thing was that it will make them promiscuous. Looking for that word. It will make them promiscuous. And we told them that that wasn't the purpose of the HPV vaccination. And it goes along with the messages of the ABC. So A, abstain, because if you don't go having sex, you are free from many other troubles aside having sexually transmitted infection. So the A is then be faithful to one partner and then condom. So we reassured them that we will prefer and we continue to preach that abstinence for children, for adolescents, you shouldn't be having sex as a child. And that reassured many of them to a large extent. And for some of them, using yourself as an example, as a healthcare professional. So I told them that my daughter has been vaccinated. I was actually waiting and looking to do that soon. And once it's now free, I even get to save some money. So that can also be helpful in some cases.
Thank you very much. Online speakers, online participants, sorry. If you have a question, you can raise your hand and we will mute you and then you can speak. By meantime, we're going to have 3 in person for now, starting from 1, 2. Let's go to the back.
Yeah, thank you very much, sir. Noting the significant achievement in terms of introduction of the HPV, I think 85% average of untreated miscarriages. I had a question which I think you dealt lightly with in terms of the inability to achieve and the role of the media in reducing what you call it, achieving your target. You have outlined some of the strategies, and I was wondering, this is preemptive part of that was great. going forward, are you still engaging media to help you bring out, you said the recent one you are doing now is exciting, very good, not a lot of people are taking them up. What strategies are you taking to improve that? My second one is based on the patients that I see on my walking. And these are across the both males and females with laryngeal, juvenile laryngeal, papillomatosis, force, airway obstruction, bleeding, stages. They tend to be recurrent. And for such patients, part of management is to vaccinate them. Are you going to allow room for the boys, the males in this particular vaccinated or immunized in that sense?
Thank you. We had a hand up here.
Thank you. Thank you for the good presentation. Dr. Torres, I wanted to give you a bit of an insight from my perspective on why Greater Accra has a new coverage. I think everybody assumed the electives were being funded. But then from my own personal experience, I realized that there was motivation for artificial shocking because it happened to me in where I live. And it was created and you will be directed to a private facility where you can get a vaccine. And so eventually I got, but I walked in after the rollout. It was supposed to be there. And it took the senior nurse who knew who I was to get people to get a vaccine in the facility for free. Meanwhile, in the same place, I called so many, everybody was telling me that there was shopping. So you may want to consider mystery shopping and pick the naughty ones and punish a few, and you'll be amazed at the uptick. Thank you.
Yeah, thank you so much for the presentation. My question is, there are 14 years, is it 14 completed years? If a child is 14 years, 3 months, can they go for the vaccination? And my second question is, why did you settle on 14 years? And my third one is, if a 15-year-old or a 16-year-old girl would like to have the vaccine, would they have to buy or they can go through the process?
Thank you.
The last question is, if a girl is 16 years and they would like to have the vaccine, would they, maybe they will have to buy or they can go through the EPI?
Thank you very much. I think I'll start with the question on what we are doing now. Now we are emphasizing more of an in-person mobilization. What we found was that with our approach at the beginning, there was not a lot of person to speak with parents and get feedback. We had people doing more of mass information, and people had questions that they wanted to ask, they were able to ask. So we are asking the districts to actually do more of in-person. So go to the PTAs, go to the schools, to meet them directly, give them the opportunity, give you their questions or their responsibilities and meetings. Because what we're doing, it tended to be more of, oh, that's more like a one-way communication. A few people have the chance from the radio and see that you have the chance to ask you questions. And when we have questions in our head that other people will not have asked for you to address directly. So that is what our focus is more on now, not at a national level. Within this past month, January, we have cervical cancer awareness. We also did some media engagements when we have IPPS also, cervical papillomavirus society in Ghana. We also did quite a lot of work with advocacy to parents, to schools, etc., about basic vaccination. But at the program level, we are no longer doing it at a higher level. We want it to come down so everybody will have the chance to speak. And then regarding what you mentioned, thank you very much. After this, I'll try to get some feedback from you. Because I want to identify why this is happening. We have not had any shortage of the vaccine. We've never had shortage. There was a period when the vaccines were done with the vaccination, we recalled all the vaccines back, take stock, and then redistribute. And that's basically to avoid people selling them in the private sector. If we had allowed them to remain, you know how our system is. After a while, you go looking for the documentation, they'll tell you what has fallen on it, something is lost and all that. So we have to withdraw and send back. But I thought that Damien will bear me out. The vaccines are available or are supposed to be available in every public facility. If somebody is sending somebody to a private facility to go and buy the vaccines, it's totally out of what we have. Because Ghana government has invested our taxpayers' money to buy the vaccine free of charge to everybody. And we'll be very glad, in fact, obviously, we will take note of it. What we are ready to some institution to find out where these things are going on because it's completely unacceptable. And then also somebody was asking about the age. Please, once you hit 40, the day you are 40 is the last day you can take your vaccine. 40 years plus 1 is not pass. 40 years plus 2 hours is not pass. So once you hit 40, that's it. In fact, for for immunization, the target age is actually 9. We picked 9 years, but we did 9 to 40 to try and catch up another cohort beyond that age group, which is why. So after a period of time, we'll stop the 14 years. Once we are able to address, look at the figures of those who are immunizing, once the higher age groups start going down, we'll stop the 14 and stick to the 9. Because we see the data, and we see that more or less for the campaign, we're all around the same figure. So going forward, we expect the 14 to reduce because once you are immunizing, then the proportion of those who are 40 should be reducing as time is going on because the 9-year-olds are going to become 10, 12, 13. So after a while, we'll not do 14 again. So the 14 and 16, they are not passed. And if somebody is 16 years, they can take it to the private sector. So they're available in the country for more than 10 years. Unfortunately, for now, they are not under the EPI. And then my lecture, I don't know whether it's called Dr. Dead. Yes. So we spoke about those who need the vaccination, but fortunately for now, we cannot vaccinate them. For now, we cannot vaccinate them. Maybe you can make a case to the PSG when they go to NITA. NITA can speak about this. Even for that group, they would exempt them. But even that one means you have to carefully find them and target them very specifically. So we don't have it in the general population. But for now, we cannot raise them. But I've given you the way to possibly get some exemption. So maybe we should write tonight when they may consider that they are meeting. Thank you.
All right, so we're going to come
just I would like just to add a few things about vaccine. I'm Dr. Sylvain Kofi. I'm working for MSD. MSD is a manufacturer of quadrivalent vaccine used in EPI program. But this quadrivalent vaccine is indicated for boys and girls from 9 to 45 years. So that means out of EPI age from 9 to 14, boys and girls can get these vaccines on the private facility. As Dr. Potwati said, in private, this vaccine is not available, but as I know, this vaccine is registered in Ghana, so probably the private pharmacy is possible to get this. Just to give you the framework of age from 9 to 45 years of age.
Thank you. On this side, any? Okay, take one, then I'll come. Awesome. Where are the last go? One here, one, and then I'll come.
Okay, thank you so much for the presentation. Please, I want to ask if there's any HPV policy in terms of Ghana, if you have any public documents for the vaccination. I think in some other countries, they have some specifics for the dosing. They do about 2 to 3 doses. But in Ghana, how many doses are supposed to be done? Is it just a one-time dose? And then I also want to know, in terms of the types of vaccine, is it just the Gardasil or there are other types as well? Thank you. Thank you very much for very interesting presentations. My question is sort of linked to what Dr. Foy mentioned. Have you considered whether in Greater Accra, the lower numbers that you had could have been related to the fact that you have middle-class parents who may have already vaccinated their children within this age group prior to the government's initiative, was that factored into sort of the calculation of the numbers? And will that be helpful in your sort of projections moving forward? Because there are people, like you said, this vaccine has been available for years. So those who could purchase it may have done so already. I'm aware people actually did. Thank you. All right, thank you for your presentation. I know a few girls who took their vaccines, but were not issued yellow cards with their drug codes were blown up, because I know there's going to be another shot for them after 6 months. So I want to find out why.
Can you address this, Steve?
Thank you very much. I'll start with the last question. As I mentioned, during the campaign, we had shortage of the vaccination cards. However, all regions have received adequate quantities of vaccination cards and registered. And they are supposed to bring back to go and issue the cards, because they register the polling register. They know where the girls are. They are supposed to pick them out. The vaccination is a one shot. Nobody is going back after 6 months to vaccinate anybody. I'm not sure where that information came from. What we are given is one and done. And that is from research. I didn't want to go through the research or the thinking into that, because in the presentation I gave before the vaccination campaign, I went into details showing what the research was like from India, from Kenya, Tanzania, and things, which led to the SAGE, that's the Advisory Body for Immunization, giving the recommendation that a one dose was enough. So I just didn't want us to go through that, because I felt like it would be repetition. So it's just one dose. There are different types of the vaccine. There's a bivalent one, which has only 2 valents, 16 and 18. There's a quadrivalent one. Then there's a monovalent, also produced by MSC, that has nine different strains of HPV. That one provides about 99% protection against cervical cancer. In fact, that was what the NICTAD, or the Immunization Advisory Body, actually recommended. But at the time we were going to procure the vaccination, they were not available on the banking platform for us to procure. I know MSD is doing some work on that to the back end to try and get it for the country on a price neutral base. So I know that there is work trying to get it, because we are looking at giving maximum protection for our girls. So these are the various vaccines available. And the comments about the middle class, actually, to be honest, the middle class that are vaccinated are not significant. As much as we have people who are taking the vaccine, what we found was that the main blocks were the schools. People will go to schools and head teachers, proprietors will refuse to even allow you to even verify if somebody wants the vaccine or not. There was somebody, the BHO staff, who reached out to me that in their child's school, nobody had come. So we reached out to the district. District said when they went, the headmistress said she in her school, nobody vaccinates. So the parents mounted pressure on the head teacher. And the team went, they vaccinated the girls. All the parents accepted the vaccine. So we realized that there were people who had put in blocks. A lot of the blocks were artificial. They were not caused by the parents or the family who had vaccinated. The numbers who are vaccinated in the private sector are insignificant, because the vaccine is not cheap. And people in the private sector were given 2 or 3 doses, which is not what the current guidance is. When the vaccine started, it was starting with a 3-dose regimen. Then with time, it went to 2 doses. And we've had information for about at least 3 or 4 years now that 1 dose is enough. Because the vaccine has been in use long enough for us to follow the immunogenicity and realize that just 1 dose is enough to provide lifelong protection, which is why we are doing a 1 and done. The only group that have 2 doses are those who are immunocompromised. And for those ones, they are targeted specifically. So we go to the ART clinics, we know the children who have HIV and HIV, they are the ones who will go and give a subsequent dose to them. But we don't give that for general messaging, because we don't want people to know that because the staff is taking 2 doses. Then the question is, why is Amma taking 2 and me giving 1? And questions come around it. So for that group, we are targeting them a bit differently. We don't mention them in our general messaging, but it's just a 1 and done vaccination. Thank you.
Of the last 3 questions. Okay.
Thank you. So on the coverage, I want to know the position of the program on formalizing public-private partnership in immunization.
considering the fact that some caregivers would like to access private facilities right from pregnancy through the life force of the child. And then also in the urban areas, we have a lot of big pharmacies, and then some of them can also give some of these immunizations. And then also from with a question Dr. Akoi asked, so if there is a formal partnership, then it means that these private facilities, they wouldn't be holding the vaccine because already when you go there, it's also free. So what is the position of the program on the PPP immunization?
Thank you. The last two. Okay, only one left.
Thank you for your presentations. I think you started answering my questions. I wanted to find out what special considerations were made for adolescents living with HIV. You started touching on it in terms of dosing, immune response, because we know they have lower immune responses. We also know that they are more at risk. So if you could educate us a bit on that. Thank you.
Okay, please go ahead. Oh, please go ahead.
Okay, thank you. So I'll address the immune response. So what the state of the NICE have recommended is that we give them 2 doses. So the first dose, after 3 months, they can take it. After 3 months, they can take the second dose. So, but for those of us, I said, they are done, the public health units are supposed to identify them and go and immunize them in the clinics and things like that. And for them, I believe the clinic will follow up with the usual care. When they come of age, they are supposed to have the screening test done and things like that. So that's what I would say about the HIV infected or even immunocompromised. I think HIV as a test case for children with immunocompromised who are immunocompromised. And then for the PPP, I think that the EPA already went to private facilities. We may not have signed an MOU or anything with private facilities, but we do provide vaccination services along the line of private facilities. And our staff who carry them along to the outreach points. The challenge with the HPV is that unlike the childhood ones, HPV tends to be more like a walk-in. So the childhood ones, not as a schedule. When you have a baby, it takes some 4 weeks, 10 weeks, 6 weeks, 4 weeks, 10 weeks, 14 weeks, and take it again at 7 months, 6 months. They know that the mothers know the schedule in their head. So they know when to come. And with the HPV, because people have to voluntarily come, I think that's the reason why they may not carry it to those places. So we will not readily get there. That's why we are emphasizing that at least, if for national at all, the public facilities that have vaccination, the bigger health centers, polyclinics, and hospitals that offer starting services, you can get a vaccine here. Then, regarding the private facilities where we can, I think there are talks or conversations being had about vaccination, the context of the private sector, and the level of the Ministry of Health. So I don't want to preempt that. I know conversations have been had. There have been some technical working groups and things, work is ongoing. I do know that it's something that we are looking forward to. But the main thing we have to make sure is that we do not sell the routine vaccination. We've had cases where people were selling the vaccine. Then it makes it more difficult for the health workers to want to place a vaccine with you because if these vaccines are available in private facilities for sale, what's the guarantee that the one we are buying from Ghana government, replacing we have to make sure, we have to police it very strictly. So I think that I will defer to the ministry when the policy is developed and we can all work with it. But for now, they carry it along when they are going to the vaccination service. So the private facilities, during their outreach days, HPV should be available for the public there.
All right, so the last one will come from our online participants. Just 2 questions. A mother called me a week ago with the news that her 12-year-old daughter with sickle cell disease has been refused the vaccine at the school by the nurses who came to do the vaccination. So is sickle cell disease a contraindication? That's one question. The other thing has to do with the specific role pediatricians. This will go to Hilda. Pediatricians complain strengthening communication between tertiary care centers, public health units, and school-based vaccination teams to prevent missed opportunities for the HPV vaccine. Thank you.
So I'll talk about the sickle cell is not the contraindication to HPV. In fact, I would dare I say that it might even qualify as a compromised state. So such a person should not be denied vaccination. Maybe if the person can reach out to Dr. Hilda or the PSC team, we can advise them and help them get services where they will really give it to them. But I'm very surprised they are telling us that school sound not going to keep the child. I'm not sure why that is being done. Thank you. Okay, so at the national level, the Pediatric Society of Ghana works with the Ministry of Health, with the Ghana Health Service, and for immunization specifically, it's the expanded program on immunization that we work with. We also have had some collaborations and work with the Ghana Education Service, the school health program as well. If there are specific issues, we are sometimes called in to help. I mean, whether it's a committee or for advocacy or for education, we have helped. We, however, do not have any like particular formal partnership for like going to the schools to do this education. The EPI took that up with the school health program. At the same time, we are on committees, so at that level, if issues come up, we are able to make inputs and help to address. And if at any point in time they need a pediatrician to do something, then we would work on getting one to support whatever activity it is or whatever needs to be done. For the HPV vaccination program, before the introduction, there was a platform on the Committee for the Education, and then we went through the fact sheet and we helped with the education of the general public. As I sit here now, I'm not too sure what more we have to do, like additional to what we are already what we are already doing. But I would say that we remain open to supporting the expanded program on immunization, the Ghana Health Service, to ensure that children everywhere in Ghana receive the HPV vaccination. But I want to add that as you screen the under fives for vaccination, because I remember like 3 years ago, you have to ask the vaccination status of the children. Any child presenting 9 to 14 years of any condition in the hospital should also be screened. And when they are not vaccinated, they should link that with the public health units. Because I believe that in the facilities, they have a public health unit who will have the vaccine available. So let's try and link up with them, so that when the children come, this will be missed opportunities. Because once they come, I know adolescents don't like coming to hospital. And when they come, they'll come with scowls on their face, anger, and all kinds of things. But let's convince them, convince their parents, and then link them up so they can go to the clinic. And when they go to, leakage should be done such that they don't go and queue. Because the challenge is that they go to a busy place. Adolescents want to be in the hospital already. So imagine going there and say, oh, sit down and wait for us. If the linkage is done ahead of time, and immediately adolescent comes, the nurse will be detailed to go and get the vaccination for the we don't waste too much time. So I think these are things that we can do as pediatricians, pediatric nurses to improve the linkage of care. Thank you very much.
A big round of applause to our panelists, our speakers. Well, thank you very much for the dismissed. Thank you very much. All right. We're going to quickly move into our next session, and to moderate our next session is Dr. Abigail Saki. We're going to have a panel discussion, and she's going to introduce the panelists as well as the topic that we'll be discussing. Thank you.
Good afternoon. My regional director is the coordinator of the region. We've been sitting for a long time, so please can we stand as we waited for our panelists? Can we please stand? We are doing a bit of an exercise and we'll continue. I'm sure we work with children, so a bit of play here won't hurt. Please, we are singing the song, I will make you fishers of men. I'm sure some of you know, right? So wherever you hear the word that starts with F, the female sits
and any word that starts with M, the male sit. Please, are we okay? We are singing the song together. I will make you fishers. So fishers, female, we sit. Fishers, then we get up, and then the man M, you sit. So it goes like this. All right. So please let's do it together. Ready? Go. I will make you fishers of men. Fishers of men. Fishers of men. I will make you fishers of men if you follow. I said my if you follow me, hey, you are going now. If you follow me, hallelujah, I will make you fishers of men, fishers of men, fishers of men. I will make you fishers of men if you follow. If you're having any problems, so you just have to 10 minutes away. You're welcome. Please listen. Okay, so I'll be fine. One first aid. Okay, so it's my honor to moderate this important panel discussion on the theme, leaving no child behind, that advancing equitable healthcare for children, and adolescents with non-communicable diseases. So to help us with this, I'm introducing the panelists. We have from the Psychiatric Association of Ghana, Dr. Abigail Hardwood is a Ghanaian psychiatrist, mental health advocate, and public speaker with over 5 of experience in adult mental health and specialist training in child and adolescent psychiatry. She combines clinical excellence with a passion for public advocacy, education, and system level impact. She has gained recognition not only for her academic distinction, but also clinical contribution, including setting up the very first child and adolescent mental health services clinic at Olegu Teaching Hospital. Please let's welcome Dr. Abigail Hardwood. All right, our next panelist is Lieutenant Colonel Nataki Japon Osei. Sorry if I couldn't mention your name well. She's a distinguished pediatrician with a special interest in pediatric infectious diseases, particularly tuberculosis and HIV. She serves as the acting head of the pediatric division of 37 Military Hospital and is a committed member of the Pediatric Society of Ghana, where she's the chairman of the Adolescent Health Subcommittee and a member of the Research Promotion Subcommittee. She has extensive experience in the clinical and public health management of pediatric TB and HIV, and is widely recognized for a holistic, family-centered approach to child care. Please let's welcome Lieutenant Japon Osei. Our third representative is Dr. Caroline Taita, as a medical doctor and a public health specialist with over 13 years of experience advancing equitable health systems in Accra. Her earlier work focused on health systems strengthening and priority public health areas, including SRHR, gender-based violence, HIV, TB, community health programs for adolescent girls and young women, where she supported government and partners to translate policy into service delivery. She also a PhD in global health from Child adolescents in Ghana, that's issues. Okay, so from the global perspective, WHO has identified three categories when it comes to evidence-based interventions. The first one is the population-based, or we say let's talk about the best lives. These talks about the interventions that have got to do with tobacco control, policies that have to do with sugar-sweetened beverages, acid-potent taxes on sugar-sweetened beverages, promotion of healthy and diet activity. So in general, it's really reducing the risk of children right from the beginning and what we can do on the population level to reduce this risk. Secondly, is the decentralization of the interventions at the primary care level. So today there's been a lot of talk about interventions being available, especially specialized care, only at the level of regional hospitals and teaching hospitals. But it's been proven that if the care can go right down to the primary care level, and we can have screening and diagnostics and treatments right at the primary care level, it goes a long way to help with these interventions. And then thirdly is financial protection. There's been a lot of talk about national health insurance scheme and children being on the scheme, and even for those who are on the scheme, their diseases not being covered when it comes to NCS. So what can be done and what has been done in other countries is that all the NCDs for children and adolescents are coming under their national insurance scheme. So these are things that can be adopted in Ghana. I know that the FDA is working on taxes when it comes to the sugar-sweetened beverages, and these are things that we should advocate for to be hasty. The processes can be very long, but we act as advocates so that the taxes on sugar-sweetened beverages go higher. If you go to a shop and you buy bottled water and you buy a bottle of water, depending on what bottle it is, especially if it's the glass bottle, it's more expensive than Coca-Cola. So people would pick Coca-Cola and walk out of it. Only that God is ultimate wisdom. Even when you drink Coca-Cola, it's still expensive. But there should be deterrence to buying alcohol, to buying certain beverages. And another thing that I able to walk into any shop here in this country to buy alcohol, and that there should be strict regulations. This exists in other countries, and these are things that at the population level, Ghana can address to help with their risk factors. All right, the alcohol is, I think, as an 8 p.m. now, able to buy alcohol. And then sometimes the lender can ask you if you're ID, what is the so the Ghana can grant that. Right. So NCD, when we talk about NCD, mental health is something. Sometimes we distinguish or so there's some referrals, there's some more children and adolescents in Ghana, and most experience in the addictions side where the harmful substances supposed to exit. And how long do you have this?
Okay, so we know that yes, mental health rates are rising in prevalence in Ghana, especially in the adolescent age in Ghana. Studies from Marcy, both into studies and community studies are showing 7.3% to 18.6% prevalence rate. So there's no doubt that there is a all of that. But specifically for adolescents, and family, problem family in particular is an emerging problem. And when you look at a study that was done in the Northern region,
as high as 84% prevalence for gambling. And then out of that, about 1% for gambling. So we are seeing that even moving away from typical mental health disorders like anxiety, depression, we are moving towards gambling, problems with digital use, with pornography. Those are the kind of problems that we are typically seeing with the adolescents. Moving on to how we can address this, it will have to start from right from education. I think that mental health literacy should start in schools. We can teach our children about these things before you get to the point of 16, 17, and they can walk into a small sex shop and decide that they are going to stay, particularly or whatever, football match going on. So they need to know about the risk of getting well, and then learning to mental health disorders. It increases your risk of developing depression, anxiety disorders, and then it exposes them to other environments, to things like some people are increase.
So, when it comes to assessment, we are aware that we have a lot of health workers are buying, and one time workers are all over there. But then what that means is really see mental health while we see pediatric care for these children.
So we will have to use existing structures that are already. So I don't see why we cannot teach mothers about what's going on. I don't see why can't we use Zoom visits, mental health visits. You have a mental health visit, you have once a month, take a specific topic and learn about mental health and teach and learn about when you look at how we see screening when we come to the place to the kidney, to diabetes, to sickle cell disease. We should have 3 questions we are asking, and that was taking long and ask about their mental health.
I come with one question that's most of the answered by the diagnosis because we listen here. Because there's a case where mental health is a key when it comes to the truth and giving them the anyways, so let's move on to the next John say. I didn't ask for the they come from two other cities. It's right. Lieutenants and so it's I would say it's not it's a transition stage, and just like I think all of us is sometimes it's able to tell challenges. Yeah, and looks it's able to analyze and it's supposed to look like that finds the results of the okay. How next things you care about the sense of intensity. Include this transition.
Yes, as was very mentioned earlier today by Prof. Entry, there's a real gap across Ghana and many lower income lower income countries. Adolescents with non-communicable diseases often become lost of transition in pediatric services. In pediatric services, usually it's family-centered. You have a big red chaperoning you, and it's protected. But when adult service, it is your own. It is fast paced and it's less supportive. And these adolescents get lost. So even when you refer them to the adult services, you see them coming back again. And the poor continuity of care. It results in missing opportunities. Like bring out and have experience. And mental health. Our parents being in which that we have already mentioned about establishing transition limits. And this I think is very important. And transition should not just be a one-time process when a child is 18 years, we just transfer to the adult limit. However, there should be a process which would even start as early as 12 years to 18 years, where there is a clinic where we have the pediatricians and the adult care service. So that we both hand in hand, the child feels confidence, so that when at 18 years, we are transitioning this child to the adult service. It's not going to be a problem. This will help them better manage their medications and gradually build self-management skills. Secondly, we should also provide adolescents friendly NCP clinics. We should train health workers to be confident in addressing challenges that adolescents face in terms of their health. Learn how to communicate with these adolescents, ensure confidentiality and counseling. The adolescents must feel safe when they come to us and ask questions and take ownership of their health. And last but not the least, I would say that we must deliberately teach medication management, appointment scheduling. We should inform these adolescents when we are giving them appointments. We should make them understand their diagnosis. Some of our children and our adolescents don't even know their diagnosis. All the people that they come to them, they give them medications. Why they are taking medications, they do not know. Then it becomes a problem with our parents. And also, we should help them to navigate the health system. If you strengthen these transition processes, you will reduce hospitalizations, complications, and premature death. Thank you.
Public securities stay evidence because how can the sectoral collaboration strengthen the post-children service? Thank you for the question, and I think it was said that apologizing to cover this and my voice is a bit false, so it's terrible. When it comes to the roles of schools, communities, families, in terms of prevention, I think they are all uniquely positioned, strategically positioned to address NC prevention. Starting with schools. Schools have the job to share the knowledge of children and adolescents, especially in the formative years. And this is also important in the era of infodemics, where we have a lot of information flying around on social media, in the communities, etc. So schools play an important role when it comes to providing the right information, accurate information to our children. But also schools can be an excellent platform when it comes to mass screening. So I think we need to engage schools in a meaningful manner and also get them involved when we talk about screening. But also schools can offer a platform for physical education, sports, and make it fun and more interactive for children. Moving on to the communities. So obviously prevention doesn't just stop at schools. Communities also have an important role to play as community also shape the behavior and attitude of individuals. And there is an African proverb that says, it takes a village to raise a child. And when we talk about the village, I mean the community. So definitely communities such as community structures such as community healthcare workers have an important role here. And we can also break them from infectious disease, especially tuberculosis and HIV/AIDS, where they have made great strides when it comes to engaging community health workers, community health nurses, who also have community outreach programs that involve the communities at individual level also and also within their families. But also within communities, we have
religious leaders. Our children go to Sunday school every Sunday. This is also a great and excellent platform to engage our children and also equip them with the right education and information when it comes to health, lifestyle, and prevention, and so forth. And when it comes to family unit is a very important structure, and also families shape the health behavior and attitude of their children. So it is important to capacitate families with the right information in terms of healthy habits, but also just to mention a number of studies that have been conducted in sub-Saharan Africa showing that children who are born or who have parents who are obese are also more likely to become obese. And this also applies to smoking and alcohol abuse. Just also to answer your question in regards to multi-sectoral collaboration. So I think a key knowledge for us to acknowledge, a key message for us to acknowledge is that NCD or NCD prevention shouldn't sit only with the health sector. If we want to mitigate NCDs, if we want to eradicate NCDs, we have to work with other sectors. We cannot do it alone. We've spoken about schools, but we also need to engage other sectors such as nutrition, agriculture, finance, and we have to speak to each other and also foster collaboration and meaningful dialogues. And I'm also a big fan of the health in all policies approach. And what does this mean? This means that we need to integrate health, particularly NCDs, in all our policies, not just the health policies. We need to integrate NCDs into the education policies, mainstream NCDs into the agriculture policies, into the environment policies, etc. So let me close for now. Thank you.
Thank you very much, Mr. Caroline. Because of time, I will have to conclude. This is for all the panelists. We'll just go, can start with Dr. Factory. What single priority action will you urge stakeholders to commit to ensure that no child or adolescent living with an NCD is left behind over the next 5 years?
So I think if we're going to take just one priority, they will be embedding it within all our benefit packages. And for those who don't even have resources to get onto the National Health Insurance Scheme, there should be social protection for them. I think when Prof. Ingrid was speaking, he did say that, yes, even if the benefit package is there under the NHIS, there are families that can afford. There is need for other things. What is there that we can put in place for children whose parents cannot even afford the premium for national health insurance? I think once that is done, and we look at strengthening our primary health care system, it will be a matter of making sure that all the essential medicines are available right down at the primary care level. All the health workers that we need should be trained, should invest in training these health workers so that the health workers at the primary care level will at least be able to screen, identify these conditions, and when necessary, refer these children from here. So strengthening our primary health care system.
Thank you. I think one key priority would be to integrate and embed NCDs into other platforms or infrastructures that already engage or interact with children. For example, primary health care, for example, schools, for example, the community at large. And I think this will work because, one, we'll be able to reach as many children as possible and ensure that no child is left behind. Two, it is cost effective. Three, it will really focus on prevention rather than managing complications. And four, this method is easily replicable and scalable. Thank you.
Thank you. I think I also have to add my voice to the situation. For us to succeed in curbing
non-communicable disease, we need to integrate care right from the primary health level. Because if we do that, we are ensuring early detection, and we are ensuring that essential medicines are available wherever a child or adolescent finds him or herself. We need to train all categories of health workers so that they'll be confident in identifying these complications early enough and do prompt referral. If we really want to succeed in leaving no child behind, it means you need to ensure that everywhere the child is born, whether in the rural community or in the urban area, will survive and thrive. Thank you.
Lieutenant Colonel. So I would like to say that it has to be routine screening at the primary healthcare level. Screen, which means that we need to train our primary healthcare workers to be able to do such routine screening and then educate the public, families, communities, the adolescents and the children themselves, be able to know that these are the kinds of things that could happen and we need to be able to pick them up. Thank you.
Thank you. Before we discharge our analysis, we want to know if anyone in the audience has questions. Okay, we'll not be taking questions now. All right.
Thank you very much. Well, we're really way behind time, so we can take questions. I mean, the panelists are with us. So during the break, we can ask them questions. But for now, please bear with us. We are really behind time. And so thank you very much. Thank you very much.
Thank you, our panelists.
As they take their pictures, please may we invite the chairperson to give us the closing remarks. Dr. Damien Fungoyeri, Regional Director of this television.
Thank you very much. I will not attempt to repeat all that has been said because during the questions time, we had the impression that we're all awake. But there were so many questions, coming on the way of the presentations. But just for a brief, I think Prof. Samson Entry's presentation, he highlighted the challenges with pediatric ICDs. Health systems have been built around infectious diseases. So we are doing vaccination for children. But when it comes to the NCDs, the focus has always been on the adult. We know they suffer from hypertension, diabetes, but now we know children also have those challenges. So essentially, he's proposing few interventions that the things that we need to look at. Number one is to have a kind of welfare system for children because it's a chronic condition. Families are going to be overburdened. People are going to lose their work hours to be able to take care of these children. So a form of welfare system, just like a ring fence, a funding to support not just the healthcare, but their social needs, was one of the ways to tackle the challenges of STDs among children and adolescents. Funding support for pediatric medications was mentioned. There must be transition clinics for adolescents so that you have continuity of care from pediatrics through adolescent to adulthood. Integrate pediatric NCDs into a national NCD strategy implementation. You know that Ghana has developed a national NCD strategy document, and it's a bit deficient when it comes to pediatric NCDs. So there's a need to incorporate some of the issues that have been discuss procurement of equipment, training of pediatricians, and so on. Dialysis must be entirely free, and so on. Now, the HPV presentation, I won't mention it before we had an extensive discussion on it. But the good thing is that Ghana has introduced the HPV vaccination, and during the campaign, we have been able to attain 84% coverage. And we know that the Pediatric Society of Ghana played a lot of advocacy role in ensuring that the nation adopts this immunization for our kids. There were issues of disinformation, misconception, inadequate funding, including vaccination card, cold chain issues, and so on. But what the nation has done now is to routinize the HPV vaccination. So what we are saying is that any child now who gets to the age of 9 months can visit any health facility or any service delivery point, and it's entirely free. There were issues about the vaccine not being available for utilization, but from the program officer, manager, and from me, where we are at the regional level, we know all our health facilities have the vaccination. I mean, the vaccine for routine immunization. And so the question was, what would be the role of PSG in all this, including the presentation from Madam Chair. PSG should join in dispelling rumors and disinformation, but parents, you are the focal person that when they have doubt, they are likely to contact. And I'm sure when we were deploying the vaccine, many of you were called because they wanted to find out whether to take the vaccine or not. People don't trust. I mean, they ask more than they do for you. Because you trust building with you. So you should be able to give effective counseling as part of and so on. Pediatricians are the first point of call. You should be able to help us identify these opportunities for vaccination, lead in data quality for decision making, address vaccine dispensing, and build trust, build community confidence in under immunized population, and help reduce the zero growth children in our system, and also help in policy and advocacy, workforce development, and so on. So these were the issues that were presented. Issues about enrolling male child into the vaccination, HPV vaccination came out, and they were answered. I think one thing I'd like to add also is that, I mean, usually in public health programming, we look at equity. For now, we know that, I mean, if resources are not adequate, you want to see those at the greater risk. For now, our females are at a greater risk of getting cervical cancer. The male child will provide secondary protection, and so the focus now in the midst of resource limitation is to vaccinate our girl child. The question about the using vaccination to prevent some laryngeal problem, I think, public health takes feedback from the clinic. So if you're able to share your experiences, gather enough data that these conditions are common, publishable, and then we're able to generate enough evidence that it's a big problem, and that male children will benefit from the vaccination. I'm sure that the stakeholders will gather again and look at this. Private public participation in immunization. I can tell you that at the district level, the health service even deliberately assigned health workers to some of the private facilities, especially the community health nurses, who provide vaccination services. So they go there periodically, and that's the partnership, which has not been officialized, but because we want to capture everyone, and we know that most of the clients will prefer the private sector. We work hand in hand with them by assigning officers who go there to provide the vaccination. And I believe that maybe, once the vaccines have become available, we can explore that to also send the HPV vaccinations to the private health facilities, especially when our staff are going there, they go with the vaccines for those who need it to get that. As for the panel discussion, we heard from global perspective, we heard from perspective for adolescent health, what much our country can benefit from in addressing, stakeholders, how stakeholders can come into play in addressing the issues of adolescents and children with high burden of non-communicable diseases. So I want to thank you all for your attention, and I thank the organizers for giving me faith to chair this particular session. I really enjoyed the presentations and I've learned a lot. But I think that the discussion should not end here. This is a powerful group with a voice to influence policy. I think the issues that are coming up from these presentations should be captured in your communique and then distributed. We'll pick it up from there and see how we can influence, especially now that there are new national health policies that are coming out. The free primary health care and then the medical trust fund. The proposal that the third presenter made could be channeled into that to see whether we can ring fence some funds to possibly target children and adolescents with non-communicable disease. So thank you all for attention. God bless all of you.
Thank you so much, Dr. David, the Regional Director of Health for the Eastern Region. Lunch is served, but before we move on, please let's take note of these announcements. In the light of protecting our environment, NEC would like to announce that all our name tags will be recycled and used in our next AGSM. So please, those who are leaving today, kindly pass by the I'm sure you know the end of that line. And please, we have Usopa around, so please, right after lunch, if you want to drink water, kindly pass by their stand and take a drink with your own cup, since they don't want to use the plastic cups. We are all helping to protect our environment. And also the 360 photo booth is also set up outside. So kindly pass there after lunch and take your picture just like we did yesterday. And lastly, kindly take time or make time to pass through the booth, the exhibition booth, and then have some time with our exhibitors. Please enjoy your lunch. We are coming back after 30 minutes to start the abstract presentation. So please let's be snappy whilst we enjoy the lunches. At 3:15, at exactly 3:15. Thank you. Tia Pharmacy. Panatia Pharmacy.
Hello. Hello. Good afternoon, distinguished clinicians. My name is Pamela Boateng. I'm a rep for Panacea Pharmaceuticals. I would like to introduce Panacea Pharmaceuticals a little bit. So Panacea, we are importers of UK generics, particularly vegan medications. So all the vegan medications you might be seen in your facilities. They are all coming from the UK and they are all in good standard. So I know they are helping you with your medical needs. I welcome you all to Korea once again, and I hope you guys are enjoying your stay in the beautiful city of Laos. Great. So to start with, there is one bit of condition that we fight initially with respect to Felix, that also has some bad side effects when treating it. Now, so to start with Britain, we mostly see Britain even miss the third trimester delivery. That's when they miss they come out before their moms are able to deliver their sufficient iron supplements to them. Now, in this, leaving them at risk of giving them leaving them at risk of iron deficiency. Now, to start in this, we need to give them some necessary iron supplement that will help in tackling this iron deficiency. And also breastfeeding is not able to give them the necessary nutrients that would help people in this regard, which can also impair them of brain development, some other cognitive and immune functions. Now, mind you, the baby stomach is able to consume just about 5 ml of liquid. So giving them a product or an iron supplement that would really help them shouldn't take all the 5 ml volume in their stomach. It should be able to deliver the necessary nutrients in just minute volume. So in this regard, we have to try and prevent this iron deficiency from happening. Now, in preventing, we need to educate the mother, give them proper nutritional guidelines, proper nutritional supplements and medication, and also make sure we start this treatment very, very early, at the early stage of delivery. In choosing an iron supplement for periods, we particularly need to make sure the volume of supplement given to the kids are in minute dosages, like I said earlier. So, for example, giving them just 1 ml of supplement that would help in giving them their iron, zinc, folic, and ascorbic acid would really help them. That's emphasizing on the other supplementary nutrients that these preterm babies will need. Also, we would also wish the patient would be able to tolerate the product that is being given to him or her. Say it will taste it very well for the patient to accept it. And also for easy dosing, like I said earlier about giving the patient just 1 ml of the product, that would require the 50 milligram elemental iron the patient would need in replenishing his iron, folic, zinc, and ascorbic acid all in one. Also, we are tackled with products that has low allergic effects. Now, the product of choice that I'm particularly referring to is Ferrofan. Ferrofan baby drop is a combination of ferrous sulfate, zinc, ascorbic acid, and folic acid. Now we have ferrous sulfate in 75 milligram, zinc in 12.5 milligram, folic acid in 1 milligram, and zinc in 0.15 milligram. Ferrous sulfate in 75 milligram with 15 milligram elemental iron. That's the baby will need in replenishing iron in the preterm. Major key benefits of iron sulfate of our Ferrofan baby is that as I mentioned earlier, it contains ferrous sulfate, contains zinc, folic acid, and ascorbic acid. And I know we all know what these products are going to play in this rather than I'll just chip in just some two of it. Now, to start with, ferrous sulfate helping in blood formulation, helping in rejuvenation of the cognitive development, also helping in iron replenishment. Vitamin C helping in absorption of the iron that is being taken. Because from 6 months to 24 months, the patient needs a lot of iron, and we will need a product that will really help in absorbing this iron. And Ferrofan is able to help in that regard. Also, folic acid helping in DNA synthesis, helping in the brain development. As from 6, like I said earlier, from 6 to 24 months, the preterm baby needs a lot of iron, needs a lot of the brain not being able to develop when iron is reduced. And if it's not being able to, if an iron is reduced at this early stage, it becomes irreversible. So giving them the iron at their very early stage will really help them. So in choosing Ferrofan baby drug, you have one, you will have the ability to get recommended or the needed amount of iron. The 50 milligram elemental iron that the baby will need, you are able to deliver that. Also, we have the presence of other micronutrients that will help the iron delivery. Now, in meeting the needs of the patient and of clinicians, then we have good packaging that will help overdosing. Also, the child is able to tolerate the product. That meaning it tastes good, free from additives that would cause any allergic reaction, and it's also available in all pharmacies and OTCMS across the country. So in dosing of Ferrofan, we give 1 ml daily for 3 consecutive months. The major side effects that have been recorded is the constipation and diarrhea we all know. And also, at least we should store it in a cool, dry place and keep it away from children because it tastes very good. The children might take it themselves. So in conclusion, we say prevention is better than cure. Prescribe and administer Ferrofan baby drug to at-risk babies. And once anemia is diagnosed in infants, don't delay in prescribing Ferrofan baby drops. Thank you. I would want to introduce some few products from Panacea that would help in our day-to-day activities as pediatrics. So to start with Begatem suspension, that's artificial manufacturing. It has a good taste. So all the babies, all the pediatrics, all the pediatrics are able to tolerate very well. It has a vanilla smell. I wish I could pass a bottle of my Begatem around for you to have a smell of it. I'll do that after my presentation so you can have a feel of how the Begatem actually smells. You don't have like the AL smell you normally do when we reconstitute not the other ALs. Begatem, you are rest assured you are going to have a good day. So your proceeded kids will throw up when they are taking our AL. We have Bellatem in tablet as well. So if you want to take it in tablet as in 8480, we have it available in all the pharmacies. The last part I want to talk about is zinc suspension. That's simple suspension. We have simple suspension available in almost all the hospitals in Ghana. We are working to get some in other hospitals that is not available now. Hopefully by close of this year, it should be available or in all the hospitals across the country. Thank you so much.
Thank you so much, Manasia. The next sponsor presentation is from Pharma Symbiosis. Can we have the rep name?
Okay, hello, Grata. Hello. Hi, good afternoon. Thank you so much for the opportunity. I am Joseph, and I'm here to briefly touch on the protection of our babies or our pediatric population against invasive meningococcal disease. It's been a long day, so I'll make this very brief. So invasive meningococcal disease is basically a highly contagious and rapidly progressing infectious disease caused by the Neisseria meningitidis organism. And then this bacteria has about 12 strains, but then out of these 12 strains, only 6 have been found to cause majority of the conditions that are seen, or majority of the meningococcal infections that are seen globally. Here in Ghana and other countries in the meningitis belt, the most common serotype of this bacteria that has been shown to cause majority of, or about 80 to 85% of the meningococcal infections is the serogroup A. And this has been what has been disturbing us in the meningitis belt in Ghana as well. So in a way to tackle this, there was an introduction of a vaccine that protects both children and adults against the serogroup A. And then after the successful introduction of this vaccine, studies then show that there are now decreasing cases of the serogroup A cases in Ghana, which shows, or which is proof that the vaccine was very effective. The only issue now is the problem with emerging strains. Since 2017, the WHO is now saying that the serogroup C, W, and X have been predominant and also can cause seasonal epidemics. Here in Ghana, around 2016, there was an update by the Ministry of Health that actually established the presence of the W and C strains in Ghana. So now that there are other strains, what do we do about that? Because what is widely available is the vaccine that protects against the A strain, which is the monovalent meningococcal A strain. Thankfully, there's a guideline or a roadmap produced by the WHO, which is now currently which is now advocating that we use multivalent vaccines instead of the monovalent vaccine. Multivalent vaccines that can cover strains such as the ACWY or the ACWY and X. Thankfully, there's a quadrivalent vaccine produced by Sanofi known as Menatra, which is able to provide protection against the strains ACWY. So it's able to provide broad protection that covers the strains ACWY. So 4 more strains in addition to the A. And Menatra is currently recommended for babies between 9 to 23 months. For these babies, they need about 2 doses. The first dose is basically to prime the developing immune system, and the second dose helps build proper immunity against the ACWY strains. For children and adults between 2 to 55 years, They just need one dose for life. Yes, so for adults, they can also take Menatra because adults have actually, or young adults and adolescents have actually been found to be one of the most common carriers of this organism in the community. They are usually transient, asymptomatic carriers. They can have or carry the organism and wouldn't be sick, but probably pass it on to more vulnerable populations. So in addition to protecting themselves, Menatra helps also reduce the carriage or the number of bacteria that rest in their spirits. Yeah, so basically, you are trying to let our pediatricians be aware of Menatra so that this message can also reach our mothers and parents so they can make an informed decision. Yeah, so in the spirit of not leaving every child behind, this is something we actually are planning to leave behind, and that is the post-vaccination side effects. And one of the common culprits that causes post-vaccination side effects is the whole cell pertussis vaccine. And then this vaccine actually employs the use of the entire pertussis bacteria with all its endotoxins and other antigenic components. However, there are acellular pertussis vaccines which are currently licensed where only a few antigenic components have been isolated to be able to provide the same protection against pertussis, but with reduced reactogenicity. And a study conducted actually confirmed that out of 100,000 vaccinations that were carried out, for babies who received the whole cell pertussis vaccine, about close to 50,000 experienced either a systemic reaction or a local reaction like fever, drowsiness, redness, or swelling. But for babies who received the acellular pertussis vaccine, this was greatly reduced. So we are trying to introduce Agsm, which is Sanofi 61 baby-friendly vaccine, which employs the use of the acellular pertussis vaccine, meaning it has reduced reactogenicity. So it's going to protect our babies against diphtheria, tetanus, pertussis, inactivated polio, H influenza, and then Hep B. This was actually manufactured with the idea of reducing the reactogenicity that's associated with the whole cell pertussis vaccine. Most of the mothers we encounter usually call my Agsm the soft-like vaccine. But Agsm isn't just for a smooth immunization experience. It's a study conducted. Oh my God. There's a study conducted. There's a study conducted in polio in Poland that actually showed that if you take either the whole cell or acellular pertussis vaccine, protection wanes off after some years. After some years, the protection is waned off. So WHO is now currently recommending a booster shot in the second year of life to still protect our babies against or bring back their immunity levels against pertussis and the other DPT combination vaccines. Yeah, so that actually informs the regimen of Agsm. It follows the same 6, 10, 14 weeks schedule with a booster at 18 months. And Agsm can be given together with most of our other vaccines like the PCV vaccine, MMR, rotavirus, meningococcal, and so on. Agsm also comes as a pre-filled syringe. Agsm is a pre-filled syringe. There's no need to go and use a diluent where there's a risk of injecting only diluent or injecting only the vaccine using wrong diluent. It comes as a pre-filled syringe. All you need to do is attach your syringe and then inject your babies. Thank you very much.
Thank you very much. Pharmaceutical companies are not looking at your eyes when they're moving up your time.
We'll start our abstract presentations and we'll invite Lieutenant Colonel Natiki Japongose. She has already been introduced, so please let's receive her with a round of applause.
Thank you. Good afternoon, senior colleagues, distinguished ladies and gentlemen. Welcome to this oral abstract session under the theme, Leaving No Child Behind, Advancing Equitable Health Care for Children and Adolescents with Non-Communicable Diseases. You'll agree with me that this theme is timely, as STDs continue to place a growing burden on our young population, often compounded by delays in diagnosis, limited access to care, and gaps in long-term support. The presentations today will showcase practical research, innovation, and real-world solutions aimed at improving early detection, quality care, continuity for children and adolescents with NCDs. We are honored today to have these astute senior members as judges. They are Prof. Ebenezer Bedu, Dr. Sarah J. Atu Naja, and Dr. Emmanuel P. Abikwe. You agree with me, we would not have had any fair judges than these distinguished personalities. To our presenters, you have 10 minutes to present. You'll be notified when you are 7 minutes into your time, and after 3 minutes, you'll be signaled to end. I will encourage you to keep to the time and also for the participants to engage actively. Let's use this session to learn, connect, and strengthen our shared commitment to equitable child and adolescent health. Thank you. We'll begin by introducing our first presenter. Our first presenter is Dr. Selassie Koka. Dr. Koka is a consultant pediatric nephrologist at the Children's Hospital of Philadelphia in Pennsylvania, called CHOP for short, and an assistant clinical professor at the Perelman School of Medicine at the University of Pennsylvania. She also co-leads the Ghana CHOP collaboration, whose aim is to facilitate bi-directional clinical, educational, and research experiences amongst pediatricians in Ghana and at CHOP. Her interest in nephrology lies in taking care of children with advanced chronic kidney disease. She'll be presenting on building on legacy, growing the Ghana CHOP partnership to advance child health while learning from each other. Dr. Selassie Koka, you are welcome.
Good afternoon to everyone. I will be presenting this project on behalf of a whole group of collaborators, a lot of whom are in this room, and we are excited to share some of the outcomes of this partnership. Next slide, please. So we built the foundation of this partnership was actually based on the work of Professor Kweku Ohenefred-Paul and Ghanaian colleagues who had established a partnership to work to advance the care of children with sickle cell disease in Ghana. And based on that excellent partnership, we decided to step things up and set up a bigger partnership amongst 3 stakeholders: the Kolebu Teaching Hospital Department of Child Health, the Ghana College of Physicians and Surgeons, and the Global Health Center at the Children's Hospital of Philadelphia. As you can see on the slide, it was formally established in 2021, and all of these partnerships start with a concept. And so the initial concepts were started with virtual discussions and then ultimately finalized with bi-directional in-person visits and then ratified finally in November 2021. The main objectives of the partnership are to develop future global health leaders, both in CHOP and in Ghana, to maintain mutually beneficial bi-directional partnership and and capacity building in terms of clinical care, education, and advocacy. And then also to conduct high impact, high quality research that helps to move the care of children, especially in Ghana, forward. And one of the main things that we wanted to make sure was that we were having the pediatric health of Ghanaian children as a priority. In terms of our outcomes, we have had so far from January 2023 through to June of 2026, we would have had 14 Ghanaian senior residents and junior faculty come to CHOP to do observerships in different subspecialty fields, about 4 to 8 weeks duration. We will also have had CHOP trainees, about 9 of them come to Koibu Teaching Hospital for a global health elective. And we are beginning to expand that beyond pediatrics as well to anesthesia and such, still with subspecialists that are interested in pediatric care. And then finally, we've been able to facilitate 20 Ghanaian pediatricians to attend the Open Medical Institute pediatric courses, which are one week long courses in specific fields. So it could be palliative care, it could be oncology, and for physicians to be able to get an intensive educational experience there. In terms of research, we have been able to set up active projects, both in Kumasi and in Accra. And we have 3 projects in terms of pediatric resuscitation and emergency care, 3 in infectious disease, 1 in focus, and we had 1 informatics project as well. And all of these are in different stages, but they are all funded and some of them are close to being presented. And so we are very proud of this and continue to look for more opportunities for collaboration. And then a big part of partnerships is also sharing expertise. And so from the very beginning, we've been able to have our Ghanaian partners provide some courses on CHOP Open. So I invite everyone who is interested in this to log onto the website. It's free, has many different free lectures that help with the care of pediatric patients. And so we've had 5 faculty from Ghana and post lectures there. And we've also had faculty from Ghana present at the CHOP Global Health Conference. And last year, we actually were really excited to have a record number of physicians from Ghana present or submit and present abstracts at our Global Health Conference. And in total, we've had 12. And then from the CHOP side, we facilitated 3 points of care ultrasound courses and have had a total of 9 physicians and staff come to Ghana for visits and lectures. So in terms of lessons learned, we really have taken to heart the 4 core practices of global health partnerships as outlined up there. Communication has been a big part of the success of the program so far. And it has helped us build trust and sustain the partnership momentum. We essentially do virtual meetings every 3 to 4 months each year, and then we augment that with annual visits and bi-directionally. Shared priority setting is something that has been core to our partnership, as it allows us to feel passionate about what we are doing. And then as with any project, it's dynamic, and so flexibility and adaptability are needed. And so that's been another thing that we've worked on to keep momentum going. And then diversity and funding has allowed us to be able to use different sources to support the different projects that have been ongoing. As with any project, there are some challenges, and then there are always opportunities to grow from those challenges. And we all know that funding is not always easy to come by. And so that continues to be something that we will plan to continue to leverage the partnership and continue to pursue funding opportunities in Ghana and outside. And then the other thing is that with any new project, there is more administrative load that comes with it automatically. And comparatively, we know that there's less administrative support and for that additional admin load for our Ghana partners compared to what we get on the CHOP side. And so we'd like to, for all of us, explore opportunities to leverage new technology to reduce that burden. And then the other thing that we look to work more on over the coming years is to make sure that our partnership is adding to any existing partnerships between Ghanaian colleagues and other partners abroad so that we are not duplicating efforts. And I'll leave you with a slide that has just a few pictures. And so on the top right was a picture from our November 2021 site visit where we had the first in-person meeting. And at the bottom right was our visit to Kompanochi Teaching Hospital. And then on the left, you see some of our global health colleagues who've come to CHOP to rotate. So thank you for listening. Thank you, Dr. Fuka. We'll have questions after the next two presenters. And thank you for sticking to the time, working within time. Next on the bill is Professor Ahasa Munyin. He is a professor of pediatrics in the School of Medicine, University of Development Studies, and the medical director of Tamale Teaching Hospital. He will be presenting on Leaving No Child Behind, facility-based newborn screening for sickle cell disease as a pathway to equitable care in Northern Ghana.
Thank you so much. Good afternoon, everyone. I want to say thank you to the Pediatric Society of Ghana and then the local organizing committee for giving us the opportunity to share part of our work on newborn screening in Tamale. And this is, of course, very much in line with the non-communicable disease outlook for our 2026 AGSN. So I'm doing this presentation on behalf of a large group of people, some in Ghana and some in the United States of America. Next slide. So this project was part of my Global Scholars project grant that I had from the St. Jude Children's Research Hospital in Memphis, Tennessee, and also supported by the American Lebanese Syrian Associated Charities. So I did get funding to do this work and also funding to travel to present part of the work in different regions across the globe. Aside that, I'm not an employee of St. Jude Children's Research Hospital. So as we are all aware, sickle cell disease is very common in Ghana and across the globe. And it contributes hugely to under 5 mortality. In sub-Saharan Africa, especially, there are countries that up to 90% of the children who are diagnosed with sickle cell disease don't even make it to the 5th year of life. The key issues related to this have to do with late diagnosis, as there is yet to be a universal newborn screening program in any of the sub-Saharan African countries. And the second one is inequitable access. That can be both in-country and across countries. So, for instance, the first newborn that was screened in Ghana is almost over 30 years ago. But in Tamale and across the northern region, we only had some semblance of screening somewhere in 2020. So this shows also inequitable distribution in terms of access, even within Ghana. For newborn screening, really provides us an opportunity for early identification. This, of course, is very true for many other non-communicable diseases. And once we are able to link those that we diagnose to comprehensive care, we know that the outcomes will be very different, indeed, with very fewer complications, and then the course of the disease complications will reduce significantly. Next slide. So for this work, generally, we wanted to establish a sickle cell disease and newborn screening for sickle cell disease program internally. And then we wanted to develop strategies to be able to sustain it so that it doesn't become another pilot that after 2 years, then the whole thing comes back to zero. But there was an initial limited screening that we wanted to learn by looking at the lessons learned from that screening in Tamale in 2021. And we also aim to document the clinical progress of neonates and infants that were diagnosed through the program through a prospective cohort study. So I'm presenting some part of the work and not all of them, just focusing on what we, how many newborns we were able to screen, and then how we managed to link them to care in the next slide. So for the methodology, generally, this work was done in the Tamale Teaching Hospital. So we identified 5 sites in the teaching hospital where newborns and infants are likely to pass through. So that generally in the maternity areas and also our newborn care follow-up clinic. And then we identify 1 primary care center within the Tamale metropolis. The reason why we did this was to allow us to document whether and how feasible and acceptable newborn screening can be at the primary healthcare center compared to the teaching hospital. So we screen at 6 different centers. And the youngest baby that we screened was about 1 day, and then we screened up to 9 months of age. We use the hemotype SC point of care test, which uses a competitive immunoassay mechanism to identify hemoglobin variants A, S, and C. And generally for the hemotype SC, when the hemoglobin variant that is absent and that is present in the newborn is what will be absent on the strip when you do the testing. We got ethical approval from the Tamale Teaching Hospital to do this work. And for the results, we documented in a number of domains. One was the screening of the hemoglobin variant. The second one was documentation of the linkage to care and the sickle cell disease clinic. And we also documented the operational challenges and findings and analyzed for this presentation straightforward. Next slide. Okay. So in terms of the results for the 2 years, actually our main target was to screen every newborn that passes through the hospital. But at the end of the 2nd year, we screened about 8,500 neonates and infants. This fell a little short of the total number because in the Tamale Teaching Hospital, there were close to 11,000 babies who were born. So there were still some that we couldn't capture. For most of them were newborns, so 3/4 of those screened were newborns, and we diagnosed about 98 with either a sickle cell disease SC or SS, and we that gives us a prevalence of about 1.14% of the cohort that we diagnosed. So when you look at the distribution, we had more hemoglobin SC, almost 70% compared to the SS. This is different from what we know about the distribution in southern Ghana, especially. We did also have hemoglobin trace about 23% of AC and AS, but again, in line with the disease group also, they were more of the AC genotype compared to AS. This is important because, I mean, in our antenatal care areas, we still use sequencing to test pregnant women to see whether they have either sickle cell disease or carrier status. And in this way, one of the issues that we faced was the family would say, we were told during the antenatal that we don't have our sickle cell disease status was negative. So how come my baby has sickle cell disease? So this is one of the key issues to look at, whether this sequencing test for pregnancy screening has outpaced its relevance. Out of the 98 infants that we diagnosed, we were able to linked, and all of them are still in care, about 92.9%. This is also a huge, difference, but we know that linkage to care has been a big problem even after you have diagnosed infants of sickle cell disease. So this is the breakdown. Again, this our SC and even the hemoglobin C variant number rates are quite high, both for the trait and the sickle cell disease group. This more reflects what we see in the northern belt across the upper east, upper west, and even Burkina Faso and Togo, that the C genotype is more common. In our sickle cell disease clinic, in general, we have hemoglobin SC, but we were thinking that maybe because we diagnosed late and some of them pass away before they get to the clinic, that is why it was so. But even for these young infants as well, generally, as we saw previously, we have more of hemoglobin SC. Next slide. Yes. So these are the breakdown. Also, a large number of hemoglobin CC, about 1.35%, which was not in the previous slide. So we had quite a number of challenges. Next slide. And the key ones had to do with, we have to import the test kits, because initially we had a supplier within Ghana that was providing, and then we closed down. We had to get the test kit from outside. That was a big challenge. There were a number of invalid tests, about 0.35% of the total number. But generally, they were due to things that have to do with either the manufacturer or an infant that was transfused before the testing was done. These issues we discussed with the manufacturer during the period. And of course, cost of medications, and then some families, especially healthcare workers, that was what surprised us, that the healthcare workers were the ones that really did not want to accept that their children, infants, would have sickle cell disease. And they would say, my baby will not have sickle cell disease, God will not give my baby sickle cell disease. That was really surprising for us. And this also came, there were other issues that had to do with industrial struggle. So for conclusion, we provided access to sickle cell, early sickle cell diagnosis and timely linkage to care. And the good thing is that actually for part of the work that we did, we have been able to get support through the partnership of CHAI and the Ministry of Health to continue doing the screening. So it looks like this is not going to be a one-time, and we are hoping that in the medium time, the Ministry of Health will make this really a universal screening program. 2 days ago, in the news, there was an issue about Uganda launching a universal newborn screening for sickle cell. Then we said, well, we are richer than Uganda, so we should be able to do this. So I thank you so much for the opportunity.
Thank you very much for. So our last presenter before the question time is Dr. Nanama Agsm. The medical officer. Pediatrician, sorry. She's presented on when silence endanger life, salt wasting, congenital adrenal hyperplasia, and the cost of inevitable newborn care.
Thank you. Good evening. My name is Dr. Nanama Agsm, and I'm doing this case report on behalf of my co-authors. We entitled it When Silence Endangers Life. We have no disclosures. So I'll go through background, the case presentation, our missed opportunities, and some recommendations. So the way of background, congenital adrenal hyperplasia is a group of inherited disorders which affect the adrenals and therefore adrenal steroidogenesis. The salt-wasting congenital adrenal hyperplasia is rare, but potentially fatal non-communicable disease, as cited by Dorr et al. In their paper. So congenital adrenal hyperplasia, simply put, is a result of a defect in an enzyme which leads to reduced or defective production of the steroids. As a negative feedback mechanism, the pituitary releases adrenocorticotropin hormone, which stimulates the adrenal to enlarge in an attempt to compensate for this disorder. So why this case report? It is noted that in settings with newborn screening, early recognition is common. In contrast, in many resource-limited settings, however, delayed recognition due to inadequate knowledge of congenital adrenal hyperplasia, the limited diagnostic capacity, and poor caregiver counseling allows preventable adrenal crisis to develop. Mortality from salt-wasting congenital adrenal hyperplasia has been reported to be in the range of 2 to 13%, particularly in settings without newborn screening. Therefore, this case highlights how failure of early recognition, which we call a silence, and the diagnosis of it can transform a treatable condition into a life-threatening emergency. We want to highlight these in our objectives for understanding this case to demonstrate how failures can transform a survivable condition into a life-threatening crisis and to advocate for practical strategies to improve equity in care. Let me take you down the path of Madame N.A., who at 38 weeks walked into the hospital to deliver a healthy baby. On examination of day 1, she was told she and baby were fine and discharged home. At the child welfare clinic 2 days later for immunization, she reported that she thought the genitalia looked off. However, she was reassured baby was perfectly fine and sent home. This repeated on another visit. However, at 6 weeks, she presented to us with recurrent episodes of vomiting, diarrhea, and poor weight gain. Let's note that this child had had at least 2 prior encounters with the health system. The missed opportunity here was the fact that when we examined, we noted this child had ambiguous genitalia product stage 3. This finding was neither recognized because it was not documented in the mother's note or her child welfare clinic book, and it was not communicated to the mother as well. We thought this was a critical opportunity for early diagnosis, which was missed. This picture shows some, so this slide shows some pictures of the classic ambiguous genitalia, which I believe when you see is difficult to miss. And this was my beautiful baby NA. So that circled area was highlighting the ambiguous genitalia we noted. So our presentation, she was critically ill with features of shock requiring aggressive resuscitation. Her labs demonstrated hyponatremia, hyperkalemia, markedly elevated 17-hydroxyprogesterone levels, and abdominal ultrasound demonstrated female internal reproductive organs, confirming the disorder of sexual development. And the diagnosis made at the time was salt-wasting congenital adrenal hyperplasia with adrenal crisis. Research shows that approximately 75% of infants with classic congenital adrenal hyperplasia will have a salt-wasting adrenal crisis within the first 3 weeks of life. That is life-threatening if the disorder is not diagnosed and treated. This is why we thought this was entirely preventable. By way of follow-up care, this child was placed on lifelong glucocorticoids and mineralocorticoid therapy. A stress note was given to the parents to present it whenever they reported to the hospital with an emergency situation. A multidisciplinary approach was used in her management, and I must emphasize that her care was sustained entirely through philanthropic financial support. We had to write letters and got support, and her cost of care was about 3,000 cedis a month, which as at now her philanthropists are still doing for us. So congenital adrenal hyperplasia remains an underdiagnosed condition in Ghana, mainly due to failures in recognition, as stated by Brosnan et al. In high-resource settings, however, as we said, newborn screening allows for early diagnosis. The other thing we noted was that the child interacted with the health system, which failed her, not the caregiver, but if she had known better, she would have reported earlier. So we thought silence was a clinical risk factor in this case, mainly through diagnostic silence, communicative silence, and a systemic silence. And this highlighted the fact that maybe training for our midwives and nurses has to be strengthened because they are the first point of call when these newborns are delivered. And there may not be pediatricians everywhere to assess these children to identify simple anomalies. It was also noted that financial burden on families affects quality of care. And so, in this case, we're using congenital adrenal hyperplasia to serve as a proxy for broader challenges in equitable management of chronic non-communicable diseases in newborns, children, and stretching to the age of adolescence. What we recommend, we definitely want equity beyond technology. We're not asking for advanced technology, only for priorities. And we're starting with awareness creation, then targeted recognition training for health workers, as I said, collaborating with nursing and midwifery councils to look at the curriculum and just put make a pictorial form of how these things can simply be identified. Newborn screening, as has been said, is very important. However, in Ghana, we think it may not be scalable for now. So we want to start with the low-hanging fruits. Access to essential medicines should be strengthened through the National Health Insurance Plan. And whatever discussions we have on the table, we certainly want to make sure that children who have these chronic diseases are going to have their medications either at a subsidized cost or free. We also want to emphasize integrated psychosocial support for the families. These interventions will certainly prevent crises before they occur. In conclusion, congenital adrenal hyperplasia is a chronic non-communicable disease. The adrenal crisis is acute, fatal, and preventable. The mortality of congenital adrenal hyperplasia is largely influenced by delayed recognition and access to care. So what are we advocating for? Early recognition, which will save lives, silence, which costs lives, and equity determines survival. Equity delayed is certainly equity denied. Thank you.
I believe we've had an interesting time and we have questions for our presenters. For lots of time, we would allow 2 questions each for each presenter. So may I know if there's any question for our presenters?
Thank you very much. Which is only the last presenter that I saw. Yours was ended, so I didn't listen to it well. Thank you very much for highlighting this very neglected. We don't think. All I would say is that as pediatricians, especially newborns, when you have newborns having diarrhea, vomiting, we must look at it very carefully. Not everything is sepsis. But always we see sepsis. A lot of them metabolic disease. That's how they prevent the vomiting, all the amino acids, urea, etc. And so doing some electrolytes and acid base is useful. But for congenital adrenal hyperplasia, I mean, this sort of reason that definitely the genitalia should have alerted us. So I want to ask you, the presenter, what gender was assigned to the baby? Did they say he was a male? If it's a male, then the assignment for everybody here is to go and look at normal genitalia and see what a male genitalia looks like. Okay? You don't open your eye to look at the genitalia, look at it well. Then you see that this is really ambiguous. And so we needed a fair. We shouldn't have missed this. What gender was assigned? You say it was a male.
No, it was a female.
No. I mean, when he was born, because when you are born, then people, when the baby comes out, they will say you have given birth to a male or female. They say what?
They mentioned the mother said they told her female, and on the age chart it was documented as female.
The female.
Yes.
And they thought that this was a normal female genitalia. And most of them are midwives. They are so the assignment is having familiar with the normal genitalia of newborns. Let's look at their genitalia, so we will see the abnormal ones.
Thank you very much, Prof. Any other questions? Any other questions? So you indicate to who?
All right, thank you. The last presenter. I'm interested in the abnormality in the genitalia issue. I see that now we are having the galamsey issue resulting in a malformation of the genitalia. How are we taking more of this from the communities
Are you getting it? Now, within the community, that is where the danger is. And now, are we able to pick those things? Are we picking the pictures? Are we picking the information? How are we transmitting it all the way from the hard to reach areas to the district, to the regional, to the tertiary institution? So I wish we could get that data and then work on it. Thank you.
Any more questions? Thank you very much.
My question is to Prof. Women. Prof, maybe I didn't hear. Were there plans to screen for, to do another test for these babies at 6 months to, after the newborn screening period?
Yes, thank you so much. So when we link them to the clinic, the initial stage is what we do is the initiation of the prophylactic treatment. But then we do the confirmation at 6 months. So we use the hemotype SC initially, then subsequently after 6 months, then we do hemoglobin electrophoresis. Although data coming up is saying that you really don't need to do confirmation, but our guidelines for the newborn screening for sickle cell disease says that we should confirm. So we do the hemoglobin HP electrophoresis assessment. Thank you.
Thank you very much, everyone, for an exciting presentation. I just want to thank everybody here for all the hard work you put in for this conference. I thoroughly enjoyed it. I have 2 questions. I'm going to cheat. I'm sorry. So my first question is to Professor Hassan. My question is, you mentioned that the first baby in Ghana was screened 30 years ago. And you're still talking about screening in little bits and pieces in Ghana. So I'm just trying to figure out, I'm wondering, does it take 30 years to organize a program for newborn screening? Because that's very dismal. I mean, are we going to wait for another 30 years to get every child screened in Ghana? That was one question. My second question was to Dr. Salasi Gupta. I was just curious, you talked about all the residents who've come and who've gone. Has anything substantial happened from the relationship? Because our goal is or your goal is to train pediatricians and subspecialties. And my question is, has that enhanced the training in Ghana? And also, has that done anything to the folks in the US? Thank you.
Okay, thank you. Okay, this is your question. I'm not sure whether I'm the one to answer that question because we all know the answer that is no. Actually, we should be screening more than even sickle cell disease. But if we cannot do anything at all, this is a very common condition that has debilitating effects. So that we should screen. And for us to be doing it in practice, in pilots, in study basis, it's not really acceptable. But I think that there are good news from what I heard in the last week about what we plan to do with expanding the newborn screening. So to start with, at least we know that this year there are many more facilities within the country that will get to start screening. And then the technical working group for sickle cell disease is actually pushing, and the ministry, Ghana Health Service, is giving some promises. We hope that that comes to pass, that this will go into the primary healthcare program, which they talked about earlier this morning, about the free primary health program. And if that really happens, then we should be able to screen. If we are using the point of care, we are just looking at something below $2 per test. I mean, that should be affordable, looking at how much money we spend in other things that really don't seem to be necessary. So let's keep our fingers crossed. Thank you.
Thank you, Jackie, for your question. I would say that the easiest and the quickest answer to your question about measurable outputs is in the area of research. where we have one paper that's already ready to be submitted. We've had a few of the projects presented at conferences. And some of our trainees have been able to publish. There's one of our PICU fellows was doing a project in CAD that has been able to publish from that. And so research is definitely the place where we think things have moved forward. And from our conversations with our Ghanaian partners, this is one big field that they were wanting to see move forward. So I think that that's definitely a plus. And some of the things that change in terms of clinical care definitely will take a little bit of time. And so I haven't asked permission to share these things, but I know, for example, one of our colleagues did a neurology rotation and was interested in doing a seizure action plan, when she came back. And so I think people come back with ideas to want to implement, and our job going forward will be to follow and see what things do stick. And then in future iterations of this, we'll be able to report those outcomes. And then for our CHOP trainees, a lot of the people who come are interested in global health, and it always helps their clinical acumen, and it always helps their cultural humility. And so those are, intangible outcomes that come out of this. Thank you. Thank you, our presenters. Last but not the least is Dr. Sheila Ejewa Owusu. She's a pediatrician and a lecturer at the Tamale Teaching Hospital and the University of Development Studies Tamale. Her research interest is in pediatric infectious disease and adolescent health. She'll be presenting on I Hide, coping with anticipated stigma and ART management among adolescents living with HIV in senior high schools. Let's welcome her. Okay, so thank you. So I'll be presenting on behalf of Dr. Martin Dickens and on behalf of our host Cedric. Next slide. So we have no financial disclosures. So with the introduction of the highly active antiretroviral therapy, now most of our children are growing into adolescence. And now we are faced with many challenges, especially navigating the antiretroviral therapy. And then also other comorbidities that are associated with the conditions, including stigma, impact on their mental health, and then other chronic lung diseases. In Ghana, these adolescents living with HIV, they face most challenges, as I have talked about. And then, especially when they are transitioning into the senior high school, for most of the adolescents, this is the period that they are going to have the complete autonomy of their medications, their clinic schedules, and then other things related to their condition. And so this becomes particularly an important era. And then most of them experience anticipated stigma and then fear of disclosure of their condition. And this has an impact on the adherence of their medication, making it difficult for them to adhere to the medication. So in a clinic at Conference Teaching Hospital, we wanted to understand the social and behavioral coping strategies used by adolescents who are already in the senior high school, and then those who are now entering the senior high school. So our main objective was to explore the social and the behavioral factors that enable the adolescents living with HIV remain adherent to the antiretroviral therapies whilst they are attending senior high school. So we conducted a qualitative study and was situated at the Pediatric Infectious Disease Unit at the Confanochi Teaching Hospital. We conducted in-depth interviews and then focus group discussion. And then these participants were purposely
selected based on their sex, their age, and then whether they are in first year, second year, and third year. We wanted an equal distribution of the participants across the classes. Again, for a participant to be recruited, the participant should have had a full disclosure of the condition. So adolescents aged 15 to 19 years within this clinic were invited to participate in this study. So after the interviews, we transcribed them verbatim coded, and then the analysis was created around a framework of adolescents living with HIV that was done in Ghana by Adam Seta. So he looked at the root causes of stigma and how this impacts adolescents living with HIV. And then he came up with three main stigma experiences. So the stigma that's enacted, what they anticipate, and then what they also internalize. And to build high resilience in these adolescents or this population, then we need to have an interconnection between the school environment, their individual, so based on the knowledge of the disease, the anticipated care, the school, the clinic, and then the family that they live in. And then they also found that high resilience within this population or the adolescents help them to be able to adhere to their medication. So based on this framework, we came up with some themes. And the first one was that the participants demonstrated basic understanding of HIV. They were more open to discussing complex topics such as sexual transmission, especially adolescents. They were more worried about sexual encounters, undetected infection or undetected viral loads when we had the focus group discussion. And one interesting post was that because it helped me, it will reduce some of the virus. It will help me to be able to keep going. So their basic understanding of taking the antiretroviral therapy, this is an important quote that came out of it. Another thing that emerged, next slide. Another thing that emerged was high levels of anticipated stigma and shame, leading to extreme secrecy. So for most of these adolescents that have entered into the boarding house, we wanted to find out if they are able to talk about their condition, how many of their friends know about their condition, their house mistresses or house masters, how well have they spoken to them about their condition? And then what they said was that if they talk about their condition, then people wouldn't interact with them. So the second, a participant said that when we asked the question, he laughed and then he was like, they would distance themselves from me. So this is a reason why this participant felt that there was no need to talk about the condition to either the friends or even the house master. And the last post was that they will treat you like you are not part of their group, like you are different. And so considering some of these things, it hinders them to openly disclose their condition or talk about their condition. Next slide. Another thing that emerged, so still on the disclosure, so we realized that disclosure was limited mainly to their family, their immediate family. And then emotional challenges related to HIV were rarely discussed, even at the family level, because if the child or the adolescent is unable to talk about how the condition makes him or her feel, then other conditions or other issues surrounding adherence cannot be freely talked about. So an emerging cause was that I don't need to share it with my friend because it's private. And then another one also said that no, we don't discuss it in my family. So conditions or their adherence to medication and their own conditions are topics that even at the family level, most of these adolescents don't talk about. Next slide. Another thing that emerged also was how the students actively actively conceal their antiretroviral therapy from their peers. And so some mentioned that they put it in Mentos containers and then they hide and then take this medication. So I'll just talk about the last quote, which was very important to us. So we talked about self-reported adherence. So it was very high. And then although there was constant need for secrecy in taking the medication, we realized that these participants, they even at home, they also found it difficult to take their medication. And so when we probed further how these medications were taken in school, one participant said that I hide because she couldn't just bring out the medication for people to see while she's taking it. So for our recommendation, we are emphasizing that there is a need to train our senior high school educators or the school health program. We need really put an emphasis on it. And we know that for HIV and for other communicable diseases, there is the issue of stigma. So we need to strengthen confidentiality and then also develop structured peer and psychological support programs for the adolescents living with HIV. And we also need to create a safe and private spaces for medication adherence when they enter into the boarding school so that it becomes easier for them to take their medication. And then this transition into the senior high school, importantly the boarding houses, it intensifies their anticipated stigma. And so we need to drive a critical need for concealment that complicates the medication and management, and then disclosure among the adolescents living with HIV. So urgently, we need policies and then programmatic reforms that can incorporate some safe spaces within the boarding schools for these children or adolescents to take their medication. And the priority should be on educating the senior high school and house masters, those involved in the school health programs, so that they are able to ensure the confidentiality when they are dealing with these adolescents. Thank you. Very well presented. Please, can we have 2 questions or comments? Yes. Thank you very much for such a very lovely presentation. It takes a lot to see adolescents with HIV, and you are doing a good work. I just wanted to know, there are impressions about how the other children are going to take it. Did you by any chance find out how they got to that assertion? Was it that they had experienced it personally, or is something they heard or something they read to arrive at an impression or conclusion that children will run away from them, they'll ignore them? I just want to know if you found that out.
We take the second question so that she answers both.
Yeah, thanks, Sheila. I want to be clear about what is your recommendation on disclosure to these people who go to secondary school. I guess we are not encouraging them to go and disclose to their friends in school. Don't do that in HIV. But I didn't see it there. And so when we talk about disclosure, because what I know is like the clinics. I mean, sometimes parents don't disclose to their children who are young adolescents. That is a major challenge that we recommend that they should disclose. But not when they are going to school, they should go and disclose to whom? In the school. And that guy who is putting the medicine in a chewing gum box, if you get to see him again, he says you should change that box. Because one of the friends will say, oh, chewing gum is here, let me take one. Then he take the thing. You see. So chewing gum box is not a good thing. You find something else and put inside.
Not chewing gum. Chewing gum, there, your friend will come to let me pick. I don't know chewing gum.
Thank you very much. So Sheila, you can answer the question.
Okay, so thank you. I'll take the first one. So I as the topic said, so it's mostly anticipated stigma. It's not what they have experienced, but then based on being in the society, listening to what others go through, most of these it's just the feelings they are anticipating, what they think others may feel or may think about them. So most of them have not experienced that level of stigma, but they are anticipating that once people know their condition, this is what they will treat them. And then thank you so much, Prof. So we are not talking about them disclosing to their friends, but our emphasis was on the school health program, the teachers, house masters, so that they don't take these medication. And so for that, we just want to bring up the topic discussion policy reforms so that we train these teachers on confidentiality, especially. But we know even for healthcare workers, it's so stigmatized patients or people with HIV. So at that level, it's about the teachers so that, yes, thank you. Thank you very much. Thank you. That brings us to the end of our presentation. As we wait for our judges to collect their results, we invite a rep from African Health Supplies to give us a 5 minutes presentation. Thank you.
Good evening, everyone. My name is David Kosiadman. I'm a rep from African Health Supply as well. I handle operational activities at African Health. This is going to be a quick one. After those 5 minutes, I should come. So, as we all know, African Health, we are a medical equipment supply company. So, of course, we don't just do the supply, we also do installation, maintenance, repairs of the device. And so that is a piece about us. In fact, I'm here this evening on behalf of my boss also, Mr. Alexandra. So he's asked that we donate some equipment to the Pediatric Society of Ghana. Yes. So the equipment, well, we have majority of them at the other side, but I have a few here. And that will okay, yes, in fact, that is it. We have some balls of filters. Some BP monitors. We have about 5 Doppler's, yes. And then a handheld pulse oximeter. So we want to use this equipment to support the Pediatric Society. Yes, we do. Actually, thank you for that. We do. We have about 2 of that inside. So I don't know if a rep from PSG would come and receive this. All right. So on behalf of Africa Health, we donate this to the Pediatric Society of Ghana. Okay. Thank you so much, and I think that we both can proceed from there.
We are very grateful to African Health Supplies. Let's give them another round of applause. And please give a big round of applause to yourself. I'll invite the chairman of the Research Promotion Subcommittee of PSG to come and announce the results for the oral abstract presentations. Thank you.
Thank you very much, Lieutenant Colonel. And thank you all for your audience and for waiting patiently with us. So I'll actually be announcing the results for both the poster abstracts and the oral abstracts, and the special award for the best environmental abstract. So for the best environmental abstract, we have from exposure to ingestion, mercury poisoning in a child living in Ghana. So he takes the special award for the best abstract environmental health. So for the poster presentations, we have a tie for the first position. So one, spectrum and age at diagnosis of pediatric heart diseases in Kumasi, Ghana, a 14-year echo results review. Tie at first place, Association of Inhaled Substance Use and Respiratory Problems among Adolescents and Young Adults in Tamale. For second place, we have seizures from dual diagnosis, AARSI, developmental, epileptic encephalopathy, and interstitial hypomagnesemia, a case report. And then for third place, we have determinants of antibiotic prescription patterns in pediatric care, implications for antimicrobial stewardship. For the oral abstracts, we have two prizes. For first place, we have Leaving No Child Behind, facility-based newborn screening for sickle cell disease as a pathway to equitable care in Northern Ghana. And for the second position, we have I-HIVE, coping with anticipated stigma in So I will invite Emmanuel Okong, Vice President of the Pediatric Society of Ghana, and the President can join him to do the awards. Gabby, can you bring us their envelopes? All right, so for the poster abstracts, the first positions, the two will receive 1,200 Ghana cedis. The second position will take 1,000 Ghana cedis. And the third position, 750 Ghana cedis. For the oral abstracts, the first will take 1,500 Ghana cedis. And the second takes 1,000 Ghana cedis. So we thank all the presenters for the wonderful work you have done. And we thank you for the effort that you have put in to conduct these studies. And we hope that this will go a long way to leaving no child behind and ensuring that we promote equitable health care among Ghanaian children. Thank you all very much. It's a special prize, so the donor will donate it to us. All right. So you can take your seat and you'll be hearing from us. So I just want to take a few minutes to speak about the Research Motion Committee, the work we have been doing over the last few months. Through the leadership of the President, Dr. Hilda Boy, we have endeavored to promote research among members of the Pediatric Society of Ghana to, among others, conduct research that will directly impact policy and also improve healthcare among Ghanaian children. So when I was appointed the chair of this committee, we plan to roll out a series of activities that will promote research among us. The first package that we rolled out was to have a series of lectures on research, how to plan and roll out research. At the start of this program, we had doubts whether we would succeed. And being the realist that I am, I drew out a timetable that spanned 18 months to 24 months. Through the hard work of our president and her ability to convince lecturers to participate in this program, in about 5 months, we are almost done with all the lecture series. So join me to thank Hilda for running this program. So we have just 2 lectures in the series. Following the lectures, we now plan to give direct mentorship to individuals that will present proposals in an application that will be opening up soon. We will then pair these individuals with seasoned researchers who will then guide them over a period of 12 months to 18 months to develop and implement their research protocols. And we are hoping that this will birth a lot of researchers among us to help to promote child health in our sub-region. I would like to especially thank the resource persons and our mentors in this program. Dr. Christy Osei-Yebua is one of our mentors. We thank her very much for all the work that she has been doing. Professor Daniel Ansong is on the committee and has been mentoring us. He's not here, but we thank him so very much. We will be approaching some of you when we get to the next phase of the mentorship program. And we will urge you to try to give up your best and help us to see this through. Thank you all very much.
Thank you, Dr. Yeah. Well, too soon it comes to the end of AGSM 2026. And for my closing remarks for this last session, I will say thank you to all the presenters for an excellent and thoughtful, provoking session. Today's abstracts have been taking us across the continuum of child and adolescent health, from global partnership and capacity building to newborn screening and early diagnosis, and to equitable newborn care. And finally, to the real life experiences of adolescents living with HIV. A clear message emerges. Improving child health requires strong systems, early detection, honest communication, and supportive environments in our hospitals, our schools, and our communities. On behalf of the organizers, I thank all the presenters and our fair judges and our audience for the rich discussions we've had today. Let us continue to work together so that no child and no adolescent is left behind. Thank you.
Wow, all too soon we're coming to the end. I want to say a big thank you, but I can't do that. We're going to invite our own president to give the closing remarks, and then we'll have the vote of thanks. And then we'll wish ourselves safe journey back to where we came from. So we are almost done, please. Just give us another 5 to 10 minutes. Madam President.
Good evening. Thank you all very much for being a part of this program. At certain points during the planning, we were not sure what we will see here today, but the feedback that we have had has been very encouraging. I would like to call on all the executives here and LOC present to join me on stage. In the next minute or two, we should be done. Please clap for them. If only you knew the fights and the disagreements and the agreements and then the part and the pattern that has gone on for us to get here, your applause would be louder. And the Indefatigable Gabi is here. So on behalf of this team and anybody who is yet to come up here, I want Dr. Daniel, to all of you, thank you very much for being with us and thank you for all you do everywhere that you are. We are very grateful and we are very thankful for your continued support. We pray that God gives you the strength and replenishes whatever you may have lost over the years and gives you traveling mercy. Tomorrow we have a business meeting and that starts at 9 a.m. at the latest. We will go through the agenda items and hopefully by lunchtime we should be done and ready to go. This is for members of the Pediatric Society of Ghana. There will be a number of goodies that we have put together for you, which we hope will incentivize you to come for the meeting. So thank you very much, and I wish you the very best. There will be no vote of thanks. There will be a prayer. That's what I've added. I promise you 1 minute. Okay. Thank you all very much. God bless you. Our fight was worth it.
One of our presenters left the phone. Our presenters, you were so excited, probably one of the presenters who won was so excited and left the phone. All too soon we come to the end of another beautiful day. We are grateful to God for bringing us to this time. And so we're going to have a prayer from Dr. Gabi. Thank you. Gabi, come in. Yes.
May we bow our heads to pray. Sweet Jesus, we thank you for this evening. We thank you for this lovely weekend, this entire conference that has come to an end. We thank you for all that went into it, the planning, preparation, the traveling. We are grateful that we've come this far. For many of us, before we came here, we prayed, and now it's come to an end. We pray that you go back, you take us safely, give us genuine messages through and through. For everyone to be healthy. The things we've learned at this conference, we go back into the world and create bigger impact. and we pray we can turn things around for every Ghanaian child and children at large. Thank you for answering our prayers. Grant our heart desires. In Jesus' name we pray. Amen.
Man, we wanted a different accent. Thank you. Another round of applause to us for making this event.
My name is Francisca H. Amamu.
And I am William Abeng, your consultant MC with the SWAT. Have a good day. Hello, there are snacks at the restaurant, so on your way home or to the hotel or to have networking events, please go by the restaurant. There are snacks packed for you. You can pick it up and then wave bye-bye.